Bore da croeso I gyfarfod y bwrdd. Good morning and welcome to today's Digital Health and Care Wales board meeting, the last of 2023. We're holding the board meeting today virtually, as is our practice at the moment, and it'll be recorded and up on our website if people wish to access it in a short period of time. We are providing simultaneous translation facilities, which are accessed in exactly the same way. If people aren't aware of how to do it, if you hover your cursor over the screen, you'll get a row of icons across the middle of at the bottom of the screen, and then if you pick the globe, select the globe, and then select Hear Translation, you will then hear the simultaneous translation from Welsh to English through the meeting. We're going to be taking 2 breaks today, one a short 10-minute comfort break this morning, and then a 30-minute lunch break before we finish, and hoping to conclude at around about 2 o'clock or just after this afternoon. For board members, as you'd be aware, on the consent agenda, hopefully if there are issues that you've raised them with the relevant officer lead and they've been able to address any issues you might have had on the consent agenda. I don't intend to ask everyone to introduce themselves as usual, but I would like to extend a welcome to people attending today's meeting who don't normally join us, who you'll see through the meeting, to Paul Mason, who's our Information Standards Management Lead, and to a special welcome to Joe Mower, who's from Cardiff and Vale UHB, is an emergency medicine consultant, and they've joined us for the shared listening, and they're joining us for the shared listening and learning item today. So welcome all. And sorry, last but certainly not least, Michelle, but you're with us every meeting, Michelle. Welcome, Michelle, the Director of Planning and Performance, who we'll hear from later in the meeting. I'll now move to the agenda. Apologies for absence. We've got no apologies for absence, but I'd just like to, there's a couple of issues. Marion Wynne-Jones is with us in the meeting, but has lost her voice. So hopefully you recover your voice quickly, Marion. I'm glad you can make the meeting, and we have made facilities available if you've got any specific comments you wish to make through the meeting to do so. So I greatly appreciate you joining us whilst not feeling particularly well. And then Alistair Neil has agreed to present the highlight report for the Audit and Assurance Committee later in the meeting. 2 other items. Sam Hall isn't with us at the moment, but will be joining shortly. She's in a ministerial meeting on mental health, I believe, and will be joining us as soon as she is able from that meeting. And Ivan Evans may well have to, he will have to drop off around 11 o'clock, as he is what we call our goal command, taking over as goal command, and is dealing with an ongoing incident at the moment, and may well have to drop off through the meeting if any issues arise. But Michelle Sell will be with us through the meeting to cover anything that needs to be covered off on behalf of Ivan whilst he's not here. So thank you for agreeing to do that, Michelle. There have been no other apologies for absence, so I'll move into declarations of interest. I have not received any declarations of interest. Has anything occurred to people since they've had a chance to go through the papers? No, thank you very much. So if I move then to the consent agenda, and we've got a list here. I'll run through them. Please do indicate if something has occurred to you recently. But the first is to approve the minutes from the board meeting held on the 28th of September. People happy to do that? Thank you. To approve the private abridged minutes from the board meeting held on the 28th of September. Thank you. To approve the minutes from the annual general meeting held on the 28th of September. Thank you. To note the actions on the action log, noting both actions are marked as complete. Thank you. To note the forward work plan. To approve a very important report, the gender pay gap report. People happy to approve that? Thank you. To approve the amendments to standing orders to take account of the programme delivery committee that has been established. People happy to do that? Thank you. And then to approve, following the private board meeting, which was held just before this public board meeting, the contract award to provide a replacement for the existing SEAM solution. And I would just just take a moment out just to ask Claire on that, to give us a little bit of update on, because it's very important that we're aware this is how we are funding, how we are able to agree that this procurement in the context of our funding arrangements. Claire, would you just like to say a few words on that, please?
Yeah, thank you, Chair. Obviously, this was previously a capital item that's now moved into a recurrent revenue item. It's part of our core functionality, and together with Welsh Government, we're working to incorporate that in part of our core going forward. But it is appreciated that there is a need to do this, and we're working collectively to come to some kind of agreement on the future funding model.
Thank you, Claire. So in light of that assurance, people happy to approve that note of the meeting. Thank you. If we move then on to the main agenda, and then as ever, starting with our shared listening and learning presentation, which is urgent and emergency care work. And as usual, I will hand over to Rydian to introduce this item. Thank you, Rydian.
Thank you, Chair, and welcome again to Paul Mason and a good colleague of mine, Dr. Joe Moen. Nice to see you. My introduction would be that emergency and unscheduled care is rarely out of the news. Understanding the demand on the service, the patterns of service usage, in order to inform sensible planning decisions is a key if we're going to design safe services. As always, there's a dependency on validated data and a dependency on being able to visualize that data in a way that users can consume it. And that's the purpose of this presentation, to demonstrate how data is collected, how it is stored, and how it is presented to improve an understanding of how to manage the acute sector. So I'll hand over to Paul. Thank you very much.
Thanks, Rydian. I'll just share my screen. Okay, yep, great. Thank you. So yeah, so I'm Paul Mason, I'm the Information Standards Management Lead, and I've got Dr. Joe Moen with me as well. So Joe, do you want to introduce yourself?
Hello, hi. So as Paul says, I'm Dr. Joe Moen, Digital Lead for 6 Goals, as well as an A&E consultant in DHCW.
Thanks, Joe. So first one is yourself.
Yeah, so I've been asked to set the scene, and thank you for the invite, Chair, today. From a clinical perspective, I'm going to concentrate on 3 main areas, and that's crowding, value-based healthcare, and the unintended consequences. And I think it's fair to say at the moment, currently, we don't have a good overview of the whole urgent and emergency care system from a digital perspective in one place, although there is good data in isolation there. The whole aim of the 6 goals is to deliver the right care at the right time in the right place. And I've chosen 3 areas because crowding, we know patients don't necessarily access the right care at the right time currently, and we know that crowding does cause harm. There's good evidence from the Royal College of Emergency Medicine that patients in EDs for longer than 8 hours have an increased mortality and actually come to harm. And the same can be said of patients in secondary care. Once their acute clinical episode has completed, then patients need to get home, but often because of things that happen to them, they're in the hospital longer and they undergo something called deconditioning, which means that some of our patients don't get back to their own home and end up going to a new home, which is not really what we're trying to achieve. If I look at value-based healthcare, a lot of work of the 6 goals is actually to deliver care in the community, and we talk about step up and step down intermediate care. So this intermediate care is basically care closer to home. And again, there's good evidence that care closer to home actually delivers value-based healthcare. And there's the evidence is Prof. John Bolton in Oxford Brookes, which has really looked at actually how we transition care from secondary care into the community. And actually, there's good evidence where the finances that have been realised have been reinvested in that care in the community. And the reason that I've talked about those is because of the unintended consequences currently. So if we look at high demand in Welsh Ambulance Service is I'm going to use, that at real high escalation levels, patients are advised to go to the emergency departments. And, the department's already crowded, and we have really sick patients with heart attacks and strokes turning up in emergency departments that we don't necessarily see in a timely fashion. Now, the only way we can stop that happening is to increase patient flow and admissions from the hospital, from the emergency department into hospital, but also from the hospital back into the community care. So we actually reduce those unintended consequences. And by having all this information of a whole urgent emergency care in one place, we stop that silo way of working. So that's really hopefully given you a flavour of setting the scene from a clinical and maybe an operational point of view. Thank you, Paul.
Thanks, Joe. Thanks, Joe. So yeah, a bit of background. So the current and scheduled care dashboard doesn't give a full picture of the demands, as Joe just described, across the area. It was built on old technology, but also the data is spread across multiple dashboards and also in spreadsheets on people's desktops, and no central location for this data. There's also some poor data quality due to the inconsistencies across health boards. And then Welsh Government were also unable to access the dashboards from their desktops. And the NHS Exec and the 6 Goals programme for urgent emergency care commissioned DHCW to start developing a new dashboard, or a new urgent emergency care dashboard. So this is what the current dashboard looks like. It looks like it gives you everything you need. There are some, it's very outdated. There's things like NHS Direct on there, and there's missing demand within this. So, you're not intended to read each of these bubbles and blocks on here, but what this does show is how complex the urgent emergency care system is. It does flow from primary care to 111, out of hours 999, emergency department, our same-day emergency care and critical care, and then through to discharge. And all of this is looking to feed a dashboard that we have here. So the new features that we have in the urgent emergency care dashboard are, so we have GMS activities. So this is your GP practice. We have 111 escalation levels. We have GP out of hours, the 999 service, emergency departments, hospitals and critical care. And behind that as well, there is activity data. So we've got the GMS, so the general medical service, and so we can look at appointments, patients seen within GP practices, and the DNA levels as well. Also, we have 111 data, so this is the calls offered to the service and the abandonment rates. We also have 999 activity, which is real-time activity with call demand, ambulances en route to hospital, ambulances outside emergency departments, and also within that it has predicted demand, so the ambulance service can predict how many ambulances they need at particular times. Also, we've got emergency department data, which is real-time patients in department, and also it has historical demand as well, which is key to, I suppose, Joe's and other consultants across Wales. So now I'm going to go into a live demo, so you'll have to bear with me just to make sure this works now. So this is the current urgent emergency care escalation status dashboard. So you can see down the left-hand side, we have the areas I described, and these are updated as close to real time as possible and what is available to us at this present time. So as I said, GMS here, which is your GP practice, has the high level escalation levels for the health board, which is the highest point at that point in the day, or at that point when it was last updated. Then we have 111, and this is the level for this based on what the ambulance service feels. So this is based on staffing levels and demand. So out of hours then, out of hours is based on staffing levels across each of the out of hours services across Wales, and is updated twice a week for the week coming and the previous week as well. Then you have the ambulance service, and this is pulling real-time data into the area. Then you've got the emergency departments. Then you've got, sorry, hospitals, and this shows the hospital escalation levels across Wales. You can drill it down into site level, but I won't do that for now, for time. And then we've got critical care levels as well, across Wales. And the reason Powys is blank is it doesn't have a critical care department within Powys. So I'll jump back to the slides. So I think it's over to you, Joe. I think this is why it's important.
Yeah, so I think for the reasons I've alluded to, having a better understanding of patient flow is critical. So we actually manage our demand in a better way, more mature way, using our data to knowledge so we get the right capacity to treat our patients in a timely fashion. This is, of course, very important to the operational teams in NHS Wales and the wider picture with the NHS executive, because some of this information is not just about EDs and hospital, but actually about the community resources, and that obviously impacts impacts from planned care and primary care there. And right at the centre of this is actually Welsh Government policy and the 6 goals policy to deliver urgent and emergency care for our patients in Wales. Thanks, Paul.
Thanks, Joe. So what have we achieved on our next steps? So we've moved to a more sustainable platform. And as you can see, it gives a clearer picture of the pressures being felt across the urgent emergency care area. We also have the ability now to access this from many different devices. So in the past, we could only access it from your desktop, but now it can be accessed from your phone or iPads. Also, Welsh Government, so is a big hurdle that we've now got over, that Welsh Government are now able to access this dashboard. We have central data, so all the data now is flowing into into DHCW. So then we have access to this data. We're going to continue to build on the platform, and we are working with the 6 goals programme and policy to bring in additional feeds and working with health boards. And then we are looking to move to a more sustainable method of sharing the data, so it's not just spreadsheets as it is now. We're also looking to build in predictive analytics to look at, and because we have much more richer information at our fingertips, we can now look at the wider urgent emergency care service. And then we're looking at working with the 6 goals programme and also working with the NHS exec and policy around ongoing maintenance and support beyond the current lifetime of the funding that we have for this. I think I've got questions. I'll stop sharing my screen now.
Thank you, Paul and Joe. Oh, Ivan, you've got your hand up.
Yes, thank you, Chair. Can I just make a couple of comments? I've worked very closely with this through the 6 objectives programme, and I'd just like to thank Paul and the teams that have done so much good work over recent months. And firstly, emphasising that we've had to work very closely with people to help them to understand just how much hard work goes behind this dashboard in order to get the necessary data. And we need to find the data, collate the data, standardize it, and then feed all of the data into the dashboard. It doesn't work alone. And we have worked very closely with users in order to get the design as correct as possible so that it looks attractive. And I'm very proud of the product that we have. And then lastly, we've used our platform in order to develop this quickly, but also so that it becomes easier to develop future platforms using the same technology. So I think it shows just how we are trying to progress as a body, rather than everything working from the ground up, that we are reusing pieces of our architecture and our systems so that we can put things together sooner and they're still of a quality. So I'm very proud of the work that's been undertaken this year on this dashboard.
Thank you, Ivan. I've got David and then Helen.
Thanks, Simon. Thanks, Paul and Joe, for the presentation. 2 questions, really. From what you described, Paul, this looks like a pilot that's got potential. How do we move it from a pilot into something that's a production system that's just available to everybody that needs it? First question. And then the second question, you mentioned some using some predictive analytics on top of the information that's collated. One of the things that occurred to me would be to look at the data trends and work out when we're going to get to a critical situation before we actually get there. Is that in scope when you describe the next steps as adding some predictive analytics?
Okay, yeah, so productionizing this now, we're working with Jeremy Griffiths and Richard Bowen. So Jeremy Griffiths, he's the Chief Operating Officer, I believe, in Welsh Government, and also working with Richard Bowen, who's the Six Goals Programme Director, to look at pushing this out wider to NHS Wales. So we've got everyone, operational and clinical, using this in real time. Sorry, I missed your second part then, David.
Yeah.
It was just a clarification around your predictive analytics comment. And one of the things I think it would be really good to have would be some understanding of the situation and trends to flag up before we get to a critical situation in the service.
Yeah, that's part of the scope as well. We're working with
okay.
Richard Bowen and Jeremy Griffiths as well to then start to look at those preempting demands earlier than waiting for it to happen and then work on it. Yeah, definitely.
Okay, lovely, thank you.
Thanks, Helen, and then Alistair.
Yeah, thank you, Chair, and thank you, Paul and Joe. Really great to see this actually and see it come into life. There's been a long history to some of this unscheduled care data, isn't there, that we've many of us have been party to. So it's really great to see that being made readily available. Just a question about how then, and I guess you kind of just touched on it in your last answer, is how this integrates with the local data for operational management purposes on the ground, I guess, because lots of the local teams have some of this data that they're using kind of on a kind of minute by minute, hour by hour basis. How does this, as the national offer, actually dovetail with the local information that they've got?
Yeah, as you said, Helen, the health boards have local data and sometimes much richer data available at their fingertips. So we are working, as I said, at the moment with Jeremy and Richard, but the scope is to widen that to work with health boards to make sure we've got one source of that truth going forward, and start to get them to feel that they can use this in real time, because some of the data, as I said, is we've got some real-time data, but some is more 24 hours out of date compared to what it should be. But locally, they'll have more up-to-date information. And we're going to be working with NDR to look at bringing in more real-time data to then give it more meaning and value to it.
Thank you, Paul.
And Alistair.
Thanks, Chair. And thanks to Joe and Paul. Very good to see. I just wanted to ask about the way in which we're looking at the management of demand, and what I would also imagine is critical to this is the management of patient flow, not simply understanding of patient flow. And key to that surely must be the outward flow of patients at the other end. And that takes you back into the very well traveled territory of how we liaise with local authorities and social care. And I just wondered if you're building something in terms of your data around that, because I know that local authorities and social care settings, they have their own data centers, they have their own way of looking at this, and if we're not absolutely conjoined, then we're making difficulties where they need not exist. And just considering the advantages of making that outward end of the patient flow work just to the optimum level, considering aspects such as the cost of a bed in the NHS per night being at least £500, moving an individual back into their own home with all the benefits that can accrue with that, with the appropriate level of support, may typically be 1/5 of that. It's not always, but on average, that would be a reasonable estimate. That whole system, patient flow, seems never more critical than now. So I just was interested in your thoughts on that, Joe and Paul.
Yeah, so as part of the Six Goals programme, it does have the social care element of it, and we are working with those goal leads to look at social care activity as well and bring that data in to ensure that we have that longitudinal record, so from beginning to end. And as you said, the discharge is quite a critical part because it causes blockers, and I'm sure Joe is more clued up on that than I am.
So I come in and help you there, Paul. So we don't
really.
like to use the term blockers. These are people who have care needs that can't be provided in the environment that they're in. And the 6 Goals programme, Alistair, goal 6 basically is a home first approach and reduce the risk of readmission. You'll be well cited because you're on the board about the Welsh Community Care Information System and some of the problems that programme had in its total rollout across various elements and modules that have provided it. This is a part of a jigsaw for data predominantly for the way in, and it complements some of the other things that we do. So in the 6 Goals programme, there's signposting individuals to areas where they could receive appropriate advice. If we look at our product, for example, Choose Pharmacy, if we look at how the ambition within the NHS app to signpost people in that direction. We continue to have a problem with social care capacity. You're very familiar with the workforce and capacity issues that we have across Wales. This particular element of the programme, as I said, is part of the jigsaw, and hopefully will help contribute to a solution.
Did you want to add anything, Joe?
Well, a few things. Yeah, I mean, you're spot on there, Alistair, with that. That's what we talk about, the intermediate step up, step down care. And actually what good would look like from a data point of view is having the whole urgent emergency care system in one place. And this is the start of that dashboard building journey, if that makes sense. So yeah, spot on there. That's the intention. And that's what really I was talking about, that value-based healthcare is actually, we know that care closer to home, it offers a lot more value than care in hospital, especially when you don't need that care and your patient episode has finished.
Before I bring Rowan in, I think Ivan wants to come in on this point.
Yep, thank you, Simon. Really, your microphone was very low for me,
Yeah.
so I don't know if you want to catch up to your screen a little bit. Alistair, I chair the Digital and Data Enabling Group, which is part of the 6 Goals programme, under whose auspices this work has been undertaken. We're currently coming to the end of a discovery process, which looks particularly at discharge to recover and assess data, but it also looks at pathways through the hospital environment. And it's going to follow a similar path to the dashboard, that is, that we understand in what format data is currently collected, where and how it's collected, by whom, and then we can make decisions about how we can link the local to the national, what we can dashboard, because the data is always, the data is king or queen on your preference. You've got to have the data first. So we are reviewing to see what data we have and how then we can present it. Whether it will be through the unscheduled emergency care dashboard or through a separate dashboard is a different question, because there's a lot of information in the UEC dashboard, as you can see, but there's a limit to how much more you want to put into one portal. Sometimes there's too much, and it's better to maintain focus. So there's a lot of work going on. I think it's a really valid point, as others have reinforced.
Thanks, Ivan. Rowan.
Thank you, Joe and Paul. I just wanted to kind of reflect how much value can be created to the service when there is a ground truth that people can see of what is happening in the service, that enables better planning, and how that the data that was presented in that dashboard was not personally identifiable data. It was operational data of from the system at large, and I think it's really important to see that value. The other piece to recognize is that beyond that data, there is a series of individuals who have very, very profound healthcare needs. If people are presenting with after accidents or with strokes and heart attacks, very much kind of what the unscheduled and emergency care services for. I just wondered, Joe, what the thinking is, though, where the opportunities are to reduce demand on the service, either by encouraging people in Wales to make really good healthcare decisions, to manage their health and not see healthcare their needs become so acute that they need these services, because nobody wants to be in emergency care.
No, exactly. And that's really the aim of Goal 1, is actually supporting those patients who we know are likely to need urgent and emergency care. So whether or not that's in the form of anticipatory care planning, future care planning, support those frequent attenders for various reasons, be it mental health, be it chronic conditions. So we have a really good view of those individuals. And I think this is where this is a really complicated area. We won't do it justice in today, but actually this is where the links with the digital services for patients and public, for example, is a really good example, is actually how we can support those people so they don't end up defaulting into hospital care, that we support them better in the community by that step up intermediate care. That's an individual patient level. Yeah.
Thank you, Joe. Thank you. Thank you, Paul, and especially Joe, joining us this morning for that presentation on clearly a very important piece of work that's going on, which has very real benefits for the service and patients and citizens alike. So thank you very much for your time. And Ridgen, did you want to say anything at all in conclusion, or are you happy we move on? Okay, so if we move on then to part 4 of the meeting, and we'll start with the chair and vice chair report. There's a few things I'd just like to pick out and draw your attention to, not necessarily to add to what's in the report, but just to highlight the ministerial meeting with the chairs and chief executives. As you'd expect, a huge amount of focus on the current financial climate that I know Claire is going to pick up a little bit on later in her report, but then followed by a really useful and helpful ministerial meeting to DHCW, where we went through particularly a couple of very important areas, and I think the one I'd pick out is really just explaining to the minister what could be achieved by and what benefits could accrue in terms of safety and efficiency by just everyone using what already exists. And I think it's a really important message for us around what is out there already and what could be achieved if everyone used it. And I think she took that message, the minister took that message back with her, and hopefully find ways of getting everyone up using what is already exists in the digital space. Just briefly on the NHS Confederation Chairs meeting, just to inform you that the Jan Williams has stepped down as the chair of the policy committee, and Kirsty Williams, who's the vice chair at Powys Health Board, has taken over that role. Programme governance arrangements are moving on. You'll see from the agenda that we've had our first programme delivery committee meeting, which will bring some highlights to this meeting later today. The letters to most, if not the overwhelming majority of existing senior responsible officers went out yesterday, I believe, to inform them of the changes. And as we know, the deadline for concluding the movement to the new governance arrangements is the end of this financial year, March the 31st. Helen might want to pick up on anything in her report later, but I think that covers the development since our last board meeting. And then we had a very useful and timely, fortuitously timely roundtable discussion in the Senedd last week, the day before a tabled motion on digital in the health service, and very useful. A number of MSs present, and also some key external stakeholders were able to join us, and perhaps the chair of Llais and the new Welsh Local Government Association interim CDO. So I was really pleased that a number of our key stakeholders were able to join us for that. And as I say, it was very helpful in us being able to get across some key messages and information prior to the Senedd debate, which were picked up in the Senedd debate the following day. And then I might ask Rowan if she wants to say anything on this, but because Rowan facilitated the contact, we had a really interesting joint board conversation with some senior individuals from UMass, the University of Massachusetts Health Service, isn't it, or one of their health services in Massachusetts, on the work that they're doing around a number of areas, a couple of areas, but particularly the hospital at home service that they're running. But the interesting thing is, I mean, there's a lot of work done in homes across Wales and across the United Kingdom, but very much built on a digital platform, which was the interesting bit for us. Rowan, I don't know if you wanted to mention, and I have communicated our thanks for their time to the chief executive, because they gave us an hour and a half of their time, which was very helpful. Rowan, did you want to add anything?
I think I'd just say, Simon, that it was an enjoyable experience on both sides. I think there was a meeting of minds in terms of what everyone's trying to achieve. It was always delightful to meet, quotes, a healthcare socialist from the other side of the Atlantic. And I think they're open to further conversations if the executive and board felt it useful.
Thank you, Rowan. And it was interesting to hear the chief executive told us that he'd started his day putting his horses out. I'm not entirely sure that Helen starts her day putting her horses out. But there's the difference in the nature of the world between ourselves and America, I think, is what. So it was a great opportunity, and hopefully we'll continue those sorts of opportunities into the future. Those are the issues that I wanted to particularly highlight. Ruth, is there anything that you wanted to add to or draw attention to in your bit of the report?
Just one thing, thank you, Simon. I think obviously the vice chair's peer group, obviously very acutely aware of the challenges across the system at the moment. Vice chairs are trying to hold the space around the prevention conversation and thinking about the desire of a healthier Wales to change the system. So the last few vice chairs meetings have been focused largely on that. Obviously that's a good opportunity for us at DHCW, given so much of our work happens in the prevention space around primary care. We've got lots of discovery work going on that is relevant to that committee at the moment. And I'd particularly like to thank Sam Hall for the briefings that she gives me ahead of those meetings. Incredibly useful and also really valuable information for the vice chairs. So diolch, Sam.
Thank you, Ruth, and welcome, Sam. I know you've obviously been able to join us from your commitment to the meeting with the Minister. Any questions or comments? If not, I'll move on to... No, thank you. If I move on then to the Chief Executive's report and invite Helen to present her report.
Diolch, Chair. And yes, to your point, the closest I get to putting the horses out is to put the dog out first thing in the morning. But yeah, not so exciting. So yeah, just a couple of highlights to pick up from my report from the last couple of months. We've had our mid-year directorate reviews with all of the exec directors and their teams. So it was a great opportunity actually to hear from the teams around the first half of the year's performance and really the things that they're dealing with going forward. So I just want to say thank you actually to the whole team in terms of the preparation and for everybody that was involved in those. We had a really good conversation in October with the senior leadership team from the NHS Wales Executive. So I think lots more discussions ongoing now in terms of how we join up both the national transformation programs that are either in the executive already or are about to move into the NHS executive, and of course the clinical networks and the wider range of responsibilities that now are have all come together under the exec, and how we join that with the data and digital agenda really, and we get some of that strategic alignment and understanding and how we take things forward kind of collectively. And I think a really good example there is, with Ivan's role on the 6 goals programme with the urgent and emergency care agenda, how we can really kind of drive the value from both the digital and data agendas there. So further discussions and a bit more formality around kind of joint groups being developed now alongside Mike Emery as the CDO to facilitate some of that with the exec. And Yeah, to pick up I had the pleasure actually of joining the minister the week after she came to DHCW at a visit to Neath Talbot Hospital, where it was really great to see actually that you had clinicians who were walking through the process of using the digital tools that they've got on the ward that really is absolutely providing a positive impact and benefit to the way that they are running the wards in Swansea Bay. So I think that was a really good timing actually that the minister was able to kind of understand the offer that we provide from DHCW, the risks associated with the cyber threats that are we're continually dealing with across the health and care sector, but also to see that brought to life by clinicians actually on the front line. So yeah, really helpful visit, and I know that she thoroughly enjoyed that. And just last week we had our joint executive team meeting with colleagues from the chief exec of the NHS Wales's team in Welsh Government, where we had a chance to kind of reflect. So this was our mid-year review, so it was to reflect on the performance of the first half of the year. You'll recall we're currently under routine arrangements in terms of our monitoring arrangements with Welsh Government. It was a good discussion, really positive actually, covered previous performance and kind of that look forward into the rest of the year, and as we go into what this planning cycle for the next round of IMTP, what are the challenges really, and the issues that we're needing to draw out and deal with in terms of next year's plan. So we'll hear in due course really on the outcome of that, but really positive discussion all around. And again, just to say a big thank you to my team actually, because it's not just the work that goes into facilitating the right conversation really, and how we engage in that, but it's the work to get us there, isn't it, in terms of all that we're doing. So yeah, big shout out to the exec team and their teams in terms of all of the work that went into that, making it a positive discussion. So thank you, Chair. I think that was all from me. I'm happy to take any questions.
Thank you, Helen. Does anyone have any questions or comments? If not, we'll move on. Okay, thank you very much, Helen. If we move then on to part 5 of the agenda, the strategic items, and the first up is I'm going to invite Sam Hall, the Director of Primary Community and Mental Health Digital Services, to present the primary care strategy, which we are going to be asked to approve. Over to you, Sam.
Thank you, Chair. Well, firstly, I'm really pleased to be able to bring this to the board today. It's an opportunity to share publicly the primary care strategy and to show appreciation for my team who worked on it, and especially for the stakeholders who took the time to meet with us. They shared their honest feedback, and for want of a better phrase, they shared the things that kept them awake at night. So it was a really important activity for us to undertake. It's also an expression of the DHCW commitment to primary care as a vital element of health and care in Wales. And that's a really important thing for me and my teams to grasp hold of and work with through the strategy. This is the first strategy from my directorate. Next year, we'll look to bring community and mental health strategies that will bring together these 3 interlinked areas that really benefit from teams working collectively to create that sustainable and transformative change across an ever-stretched and much-needed services in our health service. To create the strategy, we carried out extensive research to understand the legislative and the policy environment that primary care works in. We also did a great deal of user research, both when drafting the policy and again, once we'd created a near final version. This included 40-odd stakeholder interviews, sessions with Welsh Government officers, clinicians, professional bodies, patient groups, and with internal teams, and my own teams especially, as we really wanted them to own the strategy and to be invested in its successful delivery. And I know we discussed the strategy previously during an SHA board development session, and you gave feedback on the draft strategy, and the comments there were gratefully received and incorporated, as was the feedback from the strategy socialization sessions we held when we revisited stakeholders. So I won't go through the strategy in depth, but I wanted to bring out a few of the important messages. We identified 4 principles. Delivery quality, so that we run our projects and develop our services in line with best practice and to the highest standards, maximizing the positive impact for digital products and services. Informed policy, So through our work within the system, we can help identify present and future requirements and can help shape policy decisions in health and care. We need to support policy development to reflect the change in environment and new ways of delivering care, both digitally and for those who are less digitally able. And to build value, this is through everything we do, whether it's identifying solutions, commercial or contract management, engaging with our stakeholders in a meaningful way, and of course, challenge assumptions and offer ideas and suggestions that might not be the most obvious. And the fourth one is to guide and standardize. And this is really a focus on developing and agreeing a framework for data and digital standards for adoption across primary care. If we work to agreed standards, it's easier to capture information, report, monitor, and most importantly, share information with those who need it. And of course, it allows us to take advantage of interoperability, joining solutions together to enable data to flow more securely and seamlessly through the system. Each of those 4 priorities links to one or more of 8 strategic principles. And these are things like the creation of a project and program transition function. So this is the ability to focus on landing the things that we deliver really well with our users, so they get the most from those digital improvements we make. And developing a health informatics research and reporting capability with a real focus on primary care and support from the teams already within DHCW. Development of digital futures team to look at changes across the primary care landscape and interpret those changes and developments and work with the people in the system to actually start to understand the healthcare landscape for the future. Extension of our development capability so that we can continuously improve what we offer in line with changing priorities. So this is, once we have products, how do we keep, for want of a better term, sweating our assets to keep improving them and making them deliver more and create more value. Development, as I mentioned, of our standards and guidance capability. So when people are asking us to support with that guidance and standards, we need to be able to do that. So we have to up our game and to increase our capability in that area. In implementation of some mandated and agreed processes for transition into service of new developments. And I think this is really important. We, in DHCW, we deliver a lot of things. We have a lot of programs of huge value and incredibly important to the system. But how we bring those into business as usual is really important. How they become something that can be run and managed safely and securely is really important. And also our attendance at clinical and managerial expert group meetings was something that came through very, very strongly, so that we are at the beginning of conversations and not, as sometimes happens currently in our primary care world, we're called in at the end when there's a problem. We want to make sure that we're there at the beginning so we can actually start to help design what could be a good solution for the future. And to sum up briefly before some questions, this strategy reflects the environment in which we live and work within the digital healthcare landscape, and that is rapidly changing. We're seeing opportunities for positive impact on outcomes and improvements in the levels of patient engagement, self-managed care, prevention, and major programs like the Digital Medicines Transformation Programme and the development of the NHS Wales app have given us much more opportunity through tools that are being developed to really support that wider primary care focus. And primary care is in a great position to grow in this area and help users exploit digital tools and improve their health and well-being with tools that are actually in their own hands and under their own control. And following the hopeful approval of this strategy, a delivery plan will be formed and workshops will be held with the teams that develop the clinical directorate strategies that you're about to hear today, so that we can share expertise and knowledge and join up across the organisation and really embed that primary care focus much deeper into the wider healthcare work that's done across the DHCW. And frankly, I am hugely excited by the possibilities, and I'm really pleased that we now have a strategy that can help us define our journey. And that's really important to me and my teams. We needed something, and I feel that this strategy really does that. It gives us something to really be able to focus on and to ensure that we are delivering for our wider system. So I think that I was trying to be brief, but that's
succeeded admirably, Sam. Thank you very much. That was very helpful presentation of the strategy we've been asked to consider and approve. I've got Helen, Claire, and then Alistair.
Thank you, Chair, and thank you, Sam, and yeah, well done to you and the team, really, in terms of, getting to grips within the first year, really, of having this new directorate and you as the new director to try and shape kind of our primary community mental health services to get to this clarity around the way forward for primary care particularly, but actually laying the foundations for your wider remit, I think is super commendable. There's one question for me, I suppose, in terms of one of the priority areas that you've just talked us through. It talks about the development of health informatics research and reporting capability. How does that link across to the one of the other strategies that we're going to talk about, kind of sub-strategies that we're going to talk about in terms of the intelligence strategy that Ridian's team have worked on?
Yeah, we spoke. Well, we've had a couple of sessions with the people that developed those strategies, with Rachel Powell's area, and we work really closely with them already on primary care data. And whilst it's our strategy, it's a primary care strategy, it's also part of the wider DHCW strategy. It's for us all to deliver and all to have a hand in, and we need to develop that area of our strategy with our clinical cousins in Ridian's area. And one of the things we discussed is that we will be having some cross-organizational workshops through both the strategies, actually for the 3 clinical strategies and our strategy, to work out where those synergies are and where we can get the most and the quickest and the best value out of working together to deliver them. I think we've got something to offer each other in those things, and we can support them in their strategies and they can really support us in ours. So it's not a separate thing, it's how do we leverage what we already do inside DHCW to with a focus on primary care.
Great, thank you, Sam.
Thanks. Okay, we'll take I've got a few people wanting, so Claire and Alistair, and then come back to you, Sam, and then David and Ruth, and we'll come back to you, Sam. Claire.
Okay, great strategy, Sam, and I was delighted to see quality playing a key theme throughout. My question is, having engaged with your stakeholders in developing the strategy, have you had an opportunity to share the strategy with them, and what has the response been?
Okay, Alistair.
Thanks, Chair. And as Claire said, really good to see the strategy developing, and very well done to everyone involved. My question really is, should we be considering looking ahead that social care is actually primary care, part of primary care? And just aligned to that, in what way the strategy moving forward is different to the strategy of the last 3 or 4 years?
Okay, Sam, do you want to pick up on those 2 points, stakeholder engagement, social care, primary care, and what's different, which is always a good question.
Yeah, absolutely. So the first one on engagement with stakeholders, yes, we did a lot of upfront engagement, but actually when we had a near final version, we went back out to stakeholders again and said, this is what you told us, this is how we've turned it into a strategy, this is how we believe we can deliver on what's really needed. And we asked them then to validate and to go back through that. And we reached out to them again, actually took up more of their time, and incorporated that feedback into what we've done. So it was a real kind of round robin, and I felt very much like they were part of the journey with us. We did this over quite a quick time as well. It was just a few months, which, as you know, in strategy development can take a lot longer than that. So they were ambushed on the journey, but they were very grateful to be asked as well, which is really good. And the feedback we've had is thank goodness we're doing it, which was the first thing. We really need this. That primary care can feel like the forgotten element of healthcare quite often. And yeah, it's a massively critical part, but does lose, it kind of loses its space a little bit with the focus very much on primary care, on secondary care waiting lists and all of the big news stories. And so making DHCW actually picking this out and focusing on it was received really well, actually. And I'm really grateful for that, because if it had been received badly, it would have been a much more difficult strategy to write. And Alistair, your question. So looking ahead, where does this, so as I mentioned, the primary care strategy very much will feed into our community strategy and obviously into our mental health strategy. So we work very closely already with the community, and my leadership team in my directorate, we actually have we have social care people actually embedded in that leadership within the directorate. So they are they have come from a background where that's hugely important, that health and care aren't distanced and they're thought of together as part of the thing that supports people's quality of life and well-being. So it's really important to us, and I think those themes come through, especially around the elements in policy and us being able to influence policy. So I think that's a really important tenet. The other thing that we're doing off the back of this, and I know you and I have had separate conversations, is a development session in the new year around what does care mean in reference to digital health and care Wales. So what does that really mean for us? And we're developing that session to go through with all of us, so that we can really get under the lid of that for us as an organisation. And as this moves into the community space, we are hearing from our stakeholders in primary care that a lot of what they are doing isn't necessarily healthcare now. It is offering advice and support, and that's actually putting a strain on what they do in the healthcare space. So how do we better support that care piece? Talking to people that working in GP practices, saying that actually one of the biggest areas of referral for them is to citizens advice bureaus and charities. That's because this is a wider community issue. And so we absolutely have not lost sight of that. And it's a real big element for our forward view. And as for how the strategy has changed, we didn't have a primary care strategy. There hadn't been one since 2015. And that was obviously in a previous organisation. So how it's changed is much more around that forward thinking of future, being able to really focus on the fact that we have a changing environment and population. We're aging. We're going to have a frailer organisation. We won't have a frailer organisation. We're all tough, but a frailer community, and we need to work out how we're going to do that. That technology will be a big support for that in the future. So how do we get on the front foot with that and start thinking about how we're going to look in 10 years' time now, and make those changes now and build that up in our primary care, especially around prevention, independent living, care closer to home. It is absolutely a feature for us for the future in the strategy.
Thanks, Sam. And David and Ruth, and then come back to you, Sam, and I know Chris wants to come in as well at the end. David.
Thanks, Simon. Thanks, Sam. Really great piece of work, Sam. I fully support approval of the strategy. I'm really impressed by the level of stakeholder engagement that you've achieved in such a short space of time. It's always an important thing. I think there's great opportunity in what you said about using BI and predictive analytics on top of what we've got at the moment. So I'd support that. The question I had was around priority 4 is to reduce the dependency on suppliers, which I would support as a priority, but could you just expand a little bit about what you've got in mind in that regard?
Yeah, do you want to go, Ruth? Do you want to pick up your question, and then we'll come back to you, Sam, and take the two questions together?
Yeah, thanks, Simon. Again, echo comments. It's a great strategy and really good to see it. Thanks, Sam. The work that you and your team have done has been absolutely fantastic on this. I think really it's just a challenge to us as a board. I think we can't underestimate how difficult it is to hold the space in this way and work in this way, and with all the pressures that we've got on the wider system. I think, you know, we see that as vice chairs, where we start to talk about prevention agenda, and everything that I talk about is the way that we work here through this primary care strategy. So I think the challenge for us as a board is to help Sam hold the space for this, and this way of working, which is different to where the focus is across a lot of the system currently, understandably so, because of the pressures that we're facing. When we come on to talk about the risks and the board assurance framework later, you'll see how important the primary care strategy is to us as well, because so many of our key risks are impacted across here. And certainly for us as an organisation, you know, our recruitment and our training and our development of staff to ensure we've got the digital skills to help send that out into the wider system through the primary care strategy is an absolutely key area for us to be focused on. So I think it's a completely unrelated to David's question, but a different challenge for us, and something that we need to keep cognizant of as a board in how we hold this space. Thanks,
Ruth. Sam, do you want to pick up on David's question and perhaps anything you want to comment on Ruth's observations?
Yeah, of course. So David's comment was around the supplier dependency, and so that the first observation is that the primary care supplier market is really small. It's incredibly tiny. There are not a lot of people in the game necessarily, and because of that, it's actually, we are really dependent on their ability to make changes and improvements in line with where we want to go in our development. One of the things that actually has it's held us back, to be honest, is our over reliance on having a very Welsh specific system, and so we haven't been able to take advantage of developments that have happened in the bigger market, you know, in England, for instance, where they can drive change because they have bigger shares of the market. And so one of the things we really need to do is to coin an Ivan term, is kind of undragonize some of the stuff we do, and to bring it more in line, to make it more simple, to really simplify it, and then we can take advantage of those improvements that are being made and being driven, and also to increase our capability within our own organisation to actually make some improvements ourselves with some of those systems, so that we're not always reliant on going back saying, you know, we're in the queue for changes to be made, because actually these are things that we can do ourselves, and to actually take control a little bit more of that. So it's really that twofold element.
Thank you, Sam. Okay, Chris, and then Rowan, and then probably need to move on.
Thanks, Chair. Yeah, and thanks, Sam, because it's a really good strategy. My comment was just picking up a point Alistair made earlier, and I think terminology is really important here. So this is a primary care strategy, and in my head, that's the 4 contracted services, but it sets out clearly it includes prison. And I know from previous conversations it doesn't include out of hours. So the out of hours GP provision, which, you know, takes up more time in terms of not activity, but when the provision's given, than in hours primary care activity. And then community services, again, you know, health, social care, third sector, independent sector, all play a role, don't they, in community services, and clusters, again, bridge the gap to some extent between primary care and community care. And then mental health, primary care, community care, secondary care. So I think the point about social care is really well made, but it is a really complicated system out there, and it's really important in that context just to be clear on terminology, and it's great to see that clarity in the strategy.
Thanks, Chris.
Rowan.
Yeah, thank you, Sam. And I just wanted to make the point that we have to have ambition in this strategy. This is not optional. We know from the data presented to Welsh Government that we have, you know, an elderly population in Wales. We have a population that has long-term chronic diseases and are multi-morbid, and that all drives demand. So we have to find ways of supporting our citizens and taxpayers who actually fund us to do this. And I think secondly, you know, Sam, the point you made about the primary care sort of solution base as being relatively small. I would just say I think it's kind of the traditional supplier base is small, but if we don't come in with compelling solutions for the people of Wales, I think you only have to sit through television and see the direct to consumer testing, you see the wellness apps and the health apps in whichever brand of digital phone you use store. There are a lot of solutions out there, and we want to hold the ring on this. We want to make access to the citizens of Wales through a national app something that doesn't have a barrier of whether people can pay. So Sam, I commend you, and I would just say, run like hell, make it happen.
Before you come back in, Sam, I am Marion's voice. Unfortunately, Marion, I can't ask this question in Welsh, but Marion's just welcomes the development hugely, and also made the observation that it's great to hear about the extensive stakeholder engagement. Her question is, how confident are you, Sam, that you'll continue to enjoy the same level and quality of stakeholder collaboration that Marion makes the point is obviously essential to implement the strategy? Thank you for that, Marion.
Yeah, thank you. So firstly, Rowan, yeah, absolutely. We'd like to gallop. I think is the and I think it's needed. We need to increase pace around this. So yeah, absolutely hear you, and you're obviously right. The traditional market is very small, but that traditional market needs to become less traditional, or it will lose out for the things that are now being created and the opportunities that are there. So which is one of the real reasons why we want that digital futures element in this strategy, to make sure we take full advantage of that. So thank you for that. And Marion, thank you for the question. The stakeholder engagement was the best part of developing this strategy. It really was, and going out and talking to people like practice managers, GPs, the patient groups, that has we need to do more of it, and actually they welcome it. So I think the challenge will be for us that we need to make sure we keep those relationships and we strengthen them through delivery, because there's nothing worse than saying you're going to do something and they're not doing it. And so for us, it will be that the proof will be in our delivery, which is why the next phase for this is that delivery plan, which we want to go out and talk to them about. We're going to run this as though it is a product. The strategy is a product. We will do show and tells on how we deliver the strategy and what we're delivering. So we will run open sessions on the primary care strategy and what we've done against it. We've made a commitment through the team to do that, and that's a bit of a different approach, because it's not a technical delivery, but it's an important delivery for DHCW, and therefore we are transparent. We'll do it openly, and we will show the thing as we make the thing, and that's going to be our approach to that kind of stakeholder, keeping them engaged piece.
Thank you very much for that, Sam, and thank you all for your questions and observations, and clearly get take the view that there's a huge amount of support for this strategy, Sam. But just for formality's sake, are people board happy to approve this strategy? Yeah, lovely. Thank you very much, Sam. Please thank your team, because these things are always team efforts, aren't they? So please, on the behalf of the board, thank you to you, but especially thank you to your team for all the hard work getting us to this point. Okay, if I move then on to, we're going to have three other strategies today. It's the strategy day today, isn't it? Three other strategies presented to us from the and their clinical directorate strategy. So I'm going to hand over to Rydian. Rydian, hopefully your sound might be a little bit better than it was previously. So over to you.
How is that? Is that any better?
Yeah, when you're in that position, it's much better.
Okay, well, I've fiddled with all the things that the buttons that are on the machine. As any good clinician was, switch it on and see what happens. Right. So first of all, this is agenda item 5.2. I must record my thanks to three excellent people in my team: Rachel Powell, Darren Lloyd, and Stephanie Harris, who've driven this. You'll hear me often say, and I'll repeat it: we collect information, we store information securely, and we share it appropriately. And probably in this situation, I would add, and our ambition is to learn and improve from that process. And that's where you will see data to insight come in one of the elements. So the three strategies, there are three because there are three divisions within my clinical directorate, and they've gone through quite extensive consultation, refinement, and then alignment. You'll see that they've been branded in a similar way. All three of those strategies or chapters within the clinical directorate strategy have a focus on the adoption of quality, and part of my role as medical director, you're well aware, is about safety and quality and assurance. The information governance strategy also includes the compliance with BS 1008. That quality standard outlines the best practice for the implementation of operational electronic records management systems, including the storage and transmission of information. And our clinical informatists have a clinical focus on safety within our products. And of course, our very energetic business change team sit within that division, and they're very important when it comes to implementation on the ground. They also serve as a useful source of feedback, direct feedback of information from our users to those who design and develop the systems. So the cover paper that is there outlines in section 3 some of the changes that have been made since management board approval, and I hope you see that the reasoning there is clearly stated. The section 4 of the cover paper highlights specific areas for consideration. 4.1, our vision, driving value from the data, inspiring and empowering our partners, and leading the information governance compliance across Wales, noble aims. And those aims from the three elements of the different strategies have been divided into 4. You can see there's some symmetry between them. The team have worked hard to do that, and they're clearly stated. I'm not going to go into the details any further than that, because I'm conscious I'm between you and a 10-minute break. And as a urologist, I dare say some people will want that more than others, but I'm happy to take questions, Chair.
Thank you, Rydian. Questions? Helen?
Yeah.
Then David.
Not so much a question, more of an observation again. And the team really, I suppose, coming together under Rydian's directorship there, that's was a new concept when we stepped into kind of the new directorate as an SHA. But just to say that they've, the synergies and the way that the teams now work together, we knew we were right in putting those three kind of departments together and those three leaders together. And Rydian has recruited a really strong kind of leadership team there, and it's great to see this being set out in that way and how they collectively are really kind of embracing that, kind of driving the value from what we have to use out there and getting that clinical voice both within the organisation and kind of engaging out of the organisation, and that value in data and keeping data safe and using the data. So I think comes through really strongly. So I just want to say thank you to Rydian and the team really in terms of bringing this kind of and setting out a clear direction of travel for the way that the directorate is moving forward. Thank you.
Thank you, Helen. David.
Thanks, Simon. Thanks, Rydian. So I was able to go through this previously when we had the DG&S meeting a few weeks ago, and I just want to reiterate the points I made then. This is a really good piece of work, and I fully support approval of the documents. I particularly like the bit on growing our own capability in this area, because it is difficult to recruit with some of these specialist expertise that aren't readily available. The one thing I would add, Ridian, is having reflected on the session previously, and in light of some of the comments that we got back from the structured assessment that was done by Audit Wales, we may need to do a little bit more around target milestones and target dates in there. I did sort of go back through them, the board papers, with that sort of in the back of my mind, and probably felt if we were to revisit that, we may pick up the same observation. So I don't know whether that's something we can do going forward, but it probably would help us be able to scrutinise it and make sure that we keep the auditors happy.
Absolutely.
Helen, sorry, Ridian. Helen, do you want to come in on that point, and I'll come back to you then, Ridian? Did you, Helen?
Yeah, no, I was just going to say, I think that's a really valid point. And I guess what we need to do is ensure we make the joins that are clearly visible to the board and clearly to all of our stakeholders in terms of developing our IMTP, where the actions from this will actually be incorporated in terms of our milestones, and then a lot of detail in the business plan itself. So I think we just need to make sure we've got that clear read across as we develop the IMTP going forward now for next year. But that's the mechanism for where our achievement milestones and our action plans are actually set out, isn't it? So we just need to make sure that is clear when it comes back to board.
Sorry, Ridian. Yeah, I know you wanted to pick up on David's observation as well.
Yeah, David, yes, I would I concur with your views on that. You, from the previous conversations that others wouldn't have been cited on, collecting the data in its totality is the first objective that we must do if we're going to get any collective learning, because the record needs to be as content rich as possible. The fact that we have a number of mechanisms of storing information, and the fact that the NDR has gone live provides us with some opportunities, and the fact that we're working hard with Policy Leeds Welsh Government on the safe and secure sharing of information in order to learn from that information, and doing that in a national approach. For some it might seem a little bit of a slow burn, David, but we're very conscious of mistakes that have been made by neighbours, shall we say, and we want to be seen as a trusted partner in this objective.
Thank you, Ridian. Rowan, you want to come in?
Yeah, thank you, Ridian. It was a good read, and as I dived into Appendix 1 and was just sort of casting my eyes over that, I was really struck by the page where it was entitled Weaknesses. And as I read the alleged weaknesses, I would just say I don't really accept them as weaknesses. I accept them as massive opportunities, because what I see wider in the organisation, and you've described this, Ridian, we are now beginning to see investments in architecture like the NDR come online, and we have talent in the organisation that can do some really amazing things. So I just wanted to say, I think we're very well set to execute on these strategies, and I look forward to seeing the outputs from them, because we have some incredibly talented people within that directorate.
Thank you, Rowan. Ridian, is there anything? I don't think anyone else wants to come in. Is there anything you want to add in conclusion? But you'll have to say it without mute on.
Just to come back to what those weaknesses highlighted were. One was about the communication of what we're doing with our partners, and I think one can always improve communication in that respect. Utilising the skills that we have within the service, and that's the NHS as a whole, and our partners, and putting data at the centre of everything we do. So I'd agree with you. Those are weaknesses where there are opportunities.
Every weakness brings an opportunity, as Rowan has pointed out. Thank you very much, Ridian, for presenting those three very important strategies. And again, as I said to Sam Hall, please pass on the board's appreciation to the teams that have been party to putting these bringing these strategies together and presenting them to us. So people, I'll take all three together. I don't think I need to take them separately. The board happy to approve the three strategies? Yes, thank you very much indeed. Right, we are going to take a break. We're running a little bit ahead of schedule, so we can actually, on the advice of my urologist, take a 15-minute break. So it's 20 past 11. If we come back at, what would that make it? 11:35, 25 to midday. Can you all please turn your cameras and microphones off whilst we have a 15-minute break, and I'll see you back here at 25 to. Thank you. Okay, I think that's everyone back. And Ivan, you've been able to get back to us. So we will move into item 5.3, the strategic procurement report, and I'll hand over to Ivan, who I'm sure will hand over very rapidly to Michelle.
Yes, thank you. And I'll try and not be too humble as the general for the gold command for the next week, but I'll hand over to Michelle as our commercial manager in the usual manner to present the next item.
Thank you, Ivan. Good morning. So there's one contract that I'm presenting for the approval of the board to award this morning. The contract, I'll just call out some key points as usual. So the contract is part of our NHS Wales e-library service. And colleagues will remember we had a really helpful presentation a while back in terms of the benefits of this service across NHS Wales. A key component really of evidence-based decision making, I think, is where we position that. So providing content that's applicable to a wide range of stakeholders who are treating patients or planning and managing care. So really important. This particular element relates to a number of e-journals which are provided. 54 e-journals, but underneath that there's quite a lot of detailed content collections, etc. So it's quite a wide range of resources that are actually provisioned through this contract. We're proposing to award a contract for 12 months, starting in January next year. So the reason it's 12 months, so the main reason is there's a regular review and refresh of the content that's provided across NHS Wales. We've got a really good e-library service management board who are very close to this issue in looking at whether content is applicable and relevant and how often it's being accessed and used, and therefore represents the most value for money and appropriate content for our users. So quite a regular kind of review and refresh is built into this process. But we also helpfully have a framework agreement which was established by NICE, so the National Institute of Health and Care Excellence, and they've established the framework for the purpose of being able to provision this type of resource to public sector users. So we have quite an effective route to market and good conditions underneath that. So in summary, 6 suppliers. You will note, again, the reason there are 6 is because generally this content is provided by specific providers only. So the supplier really follows the IP and the content. So 6 providers, all of whom we have a history of working with successfully in Wales. The value of the contract is approximately 1.3 million. So it's quite a high level of investment, as I say, but in important content for users. And the budget for that comes through the funding allocation that we have for the library service to take that forward. I'm pleased to say we've advised Welsh Government that we are proposing to enter into a contract, and that has been duly noted. So subject to the approval of our board, we would now seek to proceed to execute the contract. Happy to take any questions.
Thank you very much, Michelle. They do seem to come around very regularly, the library contracts. I've got a hand up from Alistair and then David.
Thanks, Chair. Thanks, Michelle. And please don't misunderstand my question. I can see the absolute value of this from the report. But what would you regard this as essential? And if we didn't do it, what would be the downside?
Go on then, Michelle. Yeah, pick it up.
Yeah, I'm happy to. I mean, I think we would, from a stakeholder perspective, Alistair, this would be regarded as an essential service. I noticed that Rydian's put his hand up. I may defer to my clinical colleague, who I'm sure would be right in the middle of service provision. There's actually one of Rydian's teams who provides this service. Rydian, did you want to comment on that from a clinical perspective?
My comment would be that access to evidence-based information at any point in the delivery of care is key to high-quality medicine. They are a lot. They do cost a lot. They cost a lot because they don't have a particularly wide circulation. It's not the sort of journals you find on everyone's coffee table, but they're absolutely vital, particularly the stuff that comes through the British Medical Journal, both for continuing professional development, the CPD element of medical education and lifelong learning, but also the accessibility in emergency situations to determine that what you think is the right thing is actually the right thing.
Thank you, Rydian. David, and then Marilyn.
Thanks, Simon. Thanks, Michelle. Question really is around the scope. Is it similar to what we procured last year? And given the prevailing inflation, have we seen any escalation in the price we're having to pay?
Do you want to pick that up, Michelle?
Yeah, thank you, David. So there is some changes in the scope, as I said, as part of the review process. So broadly, there will be a kind of a core set of resources that would be consistent with that was procured last year. There will be some changes as part of the review in terms of the detailed list of content. I think that was my point earlier. We haven't seen a significant move in price. There have been some changes, as we would have expected, I think, in this and all sorts of other areas, aren't there, in terms of digital resources at the moment. But we have been able to manage the range of resources that we needed within the budget that we had available. And that's the other part of the consideration, I think, that the Library Service Management Board managed for us really effectively, is thinking about the best use of the funding we have available. If that covers your question.
Does that cover? Yep, great. We've got a few people coming in now, so take Marilyn and then Rowan, and then come back to you, Michelle, and then Helen and Ruth, and come back to you, Michelle. Marilyn.
Can I just commend the report? I think it's really extensive and it was a good read. I just wanted to say that following from what David asked really, and what Alistair said really, that actually from my point of view, what Rydian said, it's actually vital, because if we don't actually provide this resource, then people can't actually do their jobs as effectively as they would like to. And so, you know, long term, you know, that could have implications for the end user. And so from my point of view as a board member, I don't see it as something that would be optional. Like Rydian said, I think it's something that's actually essential, really. Thank you.
Indeed. Rowan.
In the same vein, I just think, you know, it's a good question to ask, but both the volume of publications increases each year. So even if the price stays the same, you're getting more content. And I think it's important to recognise that clinical colleagues' learning doesn't stop when they qualify. They are delivering care for decades after training. And so this is a fundamental resource, and this is one a bit like the old question about, you know, could we save on the training budget? The consequential cost of not supporting the clinical community with up to the date publications could be quite extensive. So good question, but I do think this one is a saving rather than a cost.
Certainly a life-saving. And for every organ there is a journal, which is the number of them. Helen, and then Ruth, and then we'll come back. I don't think there's anything need to come back on that really. There were observations rather than questions, but you might want to pick up at the end anything, Michelle. Helen, and then Ruth.
Yeah, no, just on the same theme of that, which is a really helpful challenge, I think, from Alistair. But it's just to, you know, remind the board that we had core allocation uplift for provision of the library service. It was originally part of HCIW, our sister SHA's setup, and that we were provisioning on their behalf. This now has become a direct allocation to us as part of our core. So we're obliged to ensure that we are providing a good service in this area.
Ruth.
Thanks. I think it was just on the same subject. I know, because I've asked this question to Michelle before about the value that we derive from them, that it's actually kept under review, that we're making sure we've got the right documents there. There's a lot of user engagement, and you know, in previous years the number has been different and the types of journals we have been different, because actually we're in a constant process of review to make sure that we are deriving value from the things that we are putting out there and the users are getting best value out of it as well. So I think that's the type of challenge that we need to make sure we continue to do. And I know that the team is very strongly on that. So we're absolutely supportive of proceeding with this. Thank you.
Thank you, Ruth. Michelle, anything you wanted to add in conclusion?
Just one final point, if I may. Thank you, Chair. Just reflecting on that conversation, really helpful. I think the fact that we've centralised the service has allowed us to optimise the agreements, actually. So traditionally, this would have been provided by individual health boards or individual small organisations, all trying to provision this knowledge base to their users. So the decision that was made a number of years ago to provide a central national service, if you like, across quite a significant number of users through a controlled access point has allowed us to do something much more optimal in terms of the commercial arrangement. So it's worth recognising that. It's also enabled us to develop it's a small team, but there's quite a lot of expertise in that team. And working with the Library Service Management Board, they've been able to really create quite a lot of focus in this area, which I think has helped us in terms of the service provision going forward.
Thank you very much indeed, Michelle. And Helen, you wanted to say something?
Just a quick one on that point, actually. It was a really good prompt there, Michelle, in that we have now, the service have now expanded into social care as well. So we are working with Social Care Wales colleagues in terms of resources now available to wider social care professional community as well.
Good. Okay. I think I know the answer to this question. The board are happy to approve the contract award. Thank you very much indeed. Thank you, Michelle. If we move on to item 5.4, which is a report on our IMTP, but it also includes an update on the 23-24 accountability conditions. And I think also we're going to be given an outline of the 24-25 IMTP plan, but I presume not the plan, the approach to producing the plan. And it's back to you, Ivan.
Thank you, Simon. And I will take this paper in two parts, if that's okay with you. Firstly, I'll focus on this year's IMTP, and this is the Integrated Medium-Term Plan. And just to give you an update in terms of where we are, and that includes the conditions. And then I'll take a break for comments and questions. And then I'll speak about next year's IMTP and the planning that's currently going on in terms of that. So you will remember that we submitted our IMTP for the current 3 years, which is 2020 until 2023 until 2026, I think. Anyway, it's a 3-year plan, and we did that back in March. And we went into detailed discussions quite quickly with the Welsh Government with a focus on finance. Over the summer, we've had meetings as a board, and quite a lot of work has been ongoing through Claire's team and her work, and that's on the next item on the agenda. As a result of that, it was October before the government actually formally acknowledged the IMTPs. That discussions have been ongoing, but it was October before they formally acknowledged. And as always happens, there were accountability conditions in that letter received. And these are some additional things that the government are asking us to prioritise during the year. And quite often they are things that we will have discussed with them prior to that and in agreement with them. We've responded verbally to government against those accountability conditions in 2 regular meetings. One is the IQPD, the Integrated Quality Performance and Meeting. And that was held in October after receiving the letter. And Claire and myself represented DHCW. And then in our JET meeting, and that's the joint executive team, that we all as meeting meet the government directors to discuss performance during the year. And we then discuss the accountability conditions. Helen has now responded formally to government via letter, noting what's in the letter, i.e. what's in the appendix and the paper that you have before you today. And we will be reporting to government through those regular meetings on our quality conditions. And you will know that in a number of different areas, we have met those various matters. So those are the ones that have been noted. We've received the additional accountability conditions and we've discussed those in detail with government. Helen has responded. And so we have a full audit trail. And I'll just take a break there just for any questions or comments before I go on to next year's IMTP.
Okay, thank you, Ivan. Helen.
Yeah, and it's just to draw out that, you know, as colleagues can see what's included in the detail of those accountability conditions. There was one particularly that we wanted to kind of draw out in terms of Welsh Government, the expectation that that was set out in the condition. We're meeting it in a different way, so we just wanted to be really clear about that. There was one around the delivery condition, around how we would group together certain things under one portfolio, but of course we've already set out what's in our portfolios and how we're managing that through the IMTP itself. So we wanted to be very clear with government that we already have a robust mechanism for managing the provision of the services under those portfolios, and we wouldn't be pulling kind of some of these disparate things together into another portfolio. We had set out our direction of travel in the IMTP itself, which was accepted. So that's all included within the letter.
Okay. Anyone else want to come in with any comments or questions at this stage? If not, go back to you, Ivan. Okay, back to you, Ivan.
Thank you. Before I move on to the next, perhaps I should also have mentioned that there's a professional development plan for the planning community. The program for planning, I can't remember the title actually. Anyway, it's the planning program for learning, and there's a conference that takes place twice a year and various bodies sponsor those events. DHCW sponsored the last one, that was around a month ago, and over 200 people attended that meeting, including the Minister and Judith Badgett, the Chief Exec, who spoke about the planning framework that we have ahead of us for the coming year and the position that we are currently in. However, there is no timetable or framework that has been published by government as of yet. That will normally be published in the autumn. But we are continuing with that work to develop our IMTP, even though we haven't yet formally received that program or that timetable. We are now familiar with this. You remember that last year's IMTP was far more succinct and far tighter, actually. So we've done quite a lot of work on this last year with the support of the board. So we've begun the work this year. A workshop has been held across the organisation against all of the portfolios and also Mission 5. And that gives us the core work, which then feeds into next year's IMTP. As an exec team, we will meet next week to look at this and the challenge that we have ahead of us. And I'm sure that members will welcome this. There is an ambition within the organisation and across the organisation amongst all teams to do more, to achieve more, and to move forward in terms of our strategic aims. But the challenge we have is that our resources are limited. And in order to do a number of new things, we either have to stop or slow some important things that we're already doing, or finding more efficient outcomes so that we can do more with the same amount of resources. And that will be something that we will look at in detail next week. We are expecting to be given a timetable at some point prior to Christmas. We don't believe that we will submit the IMTP formally in January. And so we will bring an update to the next meeting, showing you where we've reached in terms of drafting. By then, I would expect to have received a formal timetable and a formal framework. But everything that we've heard from our conversations with the government state that there will be no significant change. So we're continuing progressing with the same pattern that we have, trying to be as stable as we possibly can in order to bring you the latest in the new year. And then we'll progress from there.
As I recall, we signed off this year's at our March meeting, didn't we?
Yes.
Is it 2 days before we had to submit it? And that's to do to the timing of our meetings rather than anything else. Okay. Anyone got any questions or comments? David?
Thanks, Simon. Thanks, Evan. There's reference to, excuse me, to future pipeline in the report that you issued. Have we got any expectation of any new programs that are going to come down the towards us? And particularly picking up on the comment you made about limited resources, and we've got a load of new programs that we've inherited this year. So, do you anticipate anything major coming through? And my supplementary was, where are we with the iCare program that was transferring to us? Is that in scope of the IMTP or not?
Do you want to pick those up? Both those comments
yeah.
up?
So I'll answer them in a number of ways. So there are several pipelines, I think, is the thing. So there are pipelines indicated in our current IMTP about things that we want to develop as we head into next year. And an example would be the Enterprise Master Staff Index, which we know is a really important part of the work that we need to do. And in those cases, we would be having negotiations with Welsh Government about their willingness to fund, or with health boards, or seeking to release funding from our own resources by doing other things differently. There's then a pipeline of funded programs that would come from Welsh Government. Those are mapped out in next year's DPIF profile, which is already fully allocated, and those are continuity programs. So there's an expansion of the digital medicines transformation program, for example, as health boards start to deploy their own EPMA implementations. There's also a pipeline of unfunded programs that clinical networks in particular would see as really important, and digital cellular pathology would be a really good example of that everyone agrees that digital cellular pathology should and needs to be a priority, but currently there's no funding identified for it. And therefore we can't put that into our IMTP because we know it's too large for us to afford from our own resources. So I think there's quite a few things, and we're trying to manage that. And I go back to the comments that our teams are really keen. They're champing at the bit to bring in additional things. That is really welcome to see, obviously, and those things are aligned to our strategic objectives. But we have to consider ever more carefully the affordability factor of what it is that we're able to do. And some of the you'll see later on in the agenda in the IOPR where we've been forced to reprioritize some of the funding in our IMTP this year into projects that are really about reinforcing and maintaining and protecting existing infrastructure, architecture, and applications estate, and that limits our ability then to do new things, developmental features, etc.
Does that cover your points, David?
The bit you didn't cover was the iCare program. I just seeking an update on where that is.
Yeah, caught me. Sam, can I? Well, let me just prepare, and then Sam will probably want to add some details. So we have taken on the iCare program. So the iCare program, as the board knows, because the board approved the transfer of the program to us. There's a separate discussion about the existing iCare contract and the commercial arrangements, which we have not taken on. Those have not been novated to us from Cardiff and Vale. Maybe Sam wants to add some more detail. It's in her domain.
Yeah, of course.
Go on, Sam.
Thank you. Yeah, so we haven't taken on that contract. We're currently working through options around how we would take iCare forward. So iCare has some funding. It is a program. However, the work that we're currently doing is identifying where there may be shortfalls in that, and where we would need to actually go back and say, as part of the pause and reset of this work, we've identified that this now needs to be done. And needs to be done in that way, and we'll have to take that back to our Welsh Government colleagues to say, you asked us to do this, this actually is more likely what it is going to cost for us to be able to do this properly. So that's where we are. We have to get a response back to Welsh Government by the 5th of January on that.
Yeah. Okay, Rowan.
So thank you, Ivan. And I was just sort of struck as you're sort of describing the next IMTP, that it's really the middle third of the sort of long-term objective of getting to 2030 in a certain position that was laid out when DHCW was set up. And so, the challenge we've got is, we're constrained through the current financing environment at the moment. And there are some really tough choices to be made. So we talk about digital cellular pathology. It might not actually be understood more broadly how fundamental that service is in the diagnostic area into delivering really key care. So I think I've got kind of two questions. One is, how confident are we that we can maintain national services and deliver high quality additions to the service that are really important as it relates to diagnostics? And the second question is, what is the impact of having a squeeze in the digital funding in this middle third of our longer term development in terms of ending up in the place that we wanted to be in 2030? Because these are I think long, quite long investment cycles in order to get the value, and a squeeze now could mean that we don't actually deliver on what was hoped for. So just some perspective on that in terms of current funding would be
Okay,
useful.
I might invite Helen and Claire to contribute to those things on diagnostics specifically. Actually, let me just step back 1 second and say I'm really heartened, as probably came through in my update earlier. I'm really heartened and encouraged by the organisation still having the appetite to want to take on additional programs, despite everything that it's taken on over the last 3 to 4 years. If you look at all the big, significant, major transformation programs that have been initiated or that have transferred to us over the last 4 or 5 years, that's a lot of work which we are absorbing right across the organisation. It's what's behind some of the program governance changes. But still, the organisation, the people in the organisation, they've got the appetite to take on more. So can we, in the sense of, do we have the ability, the capability to take on modernisation in diagnostics like digital cellular pathology alongside Link and RISP? I'm speaking on behalf of the organisation, but yes, we can, right? We've got but can we afford to? Not unless we get more money from somewhere, because we certainly can't find the capacity to do that from our existing resources. The thing about the squeezed middle, and it is a middle if you think in a Healthy Wales perspective, or if you think in an establishment of Digital Health and Care Wales perspective for the whole decade of the 2020s, we had I thought a very open and a very sensible conversation around that at our JET meeting with Welsh Government only 2 or 3 weeks ago. And it was slightly different in flavour to maybe some of the very early JET meetings, which focused instead on our establishment as an organisation, how we were maturing, were we stable, and various other things. This was getting more into the strategic space. So I think there is a recognition, but there are no easy answers. In Claire's finance report, you can see what's in the media about the position that the NHS as a whole is in Wales. We passionately believe that digital is the answer. But we would, right? Because we're Digital Health and Care Wales. And we're working really hard to persuade our stakeholders, all of them at Welsh Government and Health Board Partner and everywhere else, to have the same conviction as we do that digital data and technology is the way out of the situation that we're currently in. But there's still work to do, I guess I would say. So that's more a reflection than an answer. I'm not sure that there's a solid answer. Clearly, the position that we've got right now is that we are being forced evermore to prioritise the maintenance of our existing services. And you will know well enough, as with other members, the longer we do that, the more technical debt we build up. And the more technical debt we build up, the more we are forced to put money into non-value adding activities to keep those things alive. And the bigger the task eventually of replatforming and moving. So we're very conscious of the challenges. Helen?
Yeah, thank you, Evan. Actually, I think you covered quite a lot of that there, isn't it? In terms of, the diagnostic piece, and when we've clearly prioritised that, but not just us as an organisation, since taking on the delivery programmes for the new laboratory system and the new radiology systems. But it's been prioritised as a system, isn't it? So that's where a great deal of the digital priority investment funding is actually going to be allocated over this year and next. And actually, they're major kind of system implementations. But Evan's right. if as a system we're deciding that digital cellular pathology is a priority, and I think the system actually does accept that we need to move that forward, then we have got to, as a system, find the money for actually making that a reality, and it would fit with our diagnostics portfolio and the skill set and the resources that we've got in place that we would need to kind of increase. But actually it would mean that it would be a holistic program of work, part of a wider diagnostic portfolio, rather than something that is happening elsewhere and then, you know, not aligned in terms of that kind of implementation and delivery. And the bit for me around the squeeze, I think, and you know, given where we are financially, is all the more important, I think, for some of the stuff that I picked up earlier in my report. The conversation with the wider system, that collaboration that we need with the wider system, with the transformation programs, with the clinical networks, the, you know, how data and digital actually becomes kind of pivotal and at the heart of those conversations, and the service redesign that is happening and needs to happen in a more kind of perhaps strategic way, that we have data and digital at the heart of that, so that we can maximize the opportunity of the investment that is available, so that we can really support that kind of recovery and transformation kind of agenda for the NHS. So that for me is absolutely it, because we can't just keep talking about the lack of money. We've got to think about actually how we're using the money that is allocated across the system in the best possible way, would be my view on that, Rowan.
I've got Claire, and then Ridian wants to come in.
I'll keep mine really brief because I'll pick it up in my finance report, Rowan, and I'll highlight why in the short term we've minimised the impact of the over longer term delivery plan for programmes. I think my observation sort of links to what's already been said, but it's an important one. It's really about the resources of the fuel that will drive the development going forward. And actually what is key is the development of those, both internally, and we've got plans to do that, and enhance the knowledge of products and the way we deliver them. But equally, it's about the recruitment of those resources. And although we've done well, we've grown the organisation to over 1,000, that challenge, that pace, keeping pace with that, is where we'll focus on the plan going forward. And it's a continual focus for us. So yeah, we are working on it, and I'll highlight it in my finance report.
Ridian.
It was just to highlight for the listener why digital cellular pathology is so important, what it actually is. So the vast majority of people who have procedures in hospitals have samples taken. Those samples need reporting to get an accurate diagnosis. If you don't have an accurate diagnosis, you can't have appropriate follow-up treatment. The workforce crisis across histopathology in the UK is dire. It's one of the most vacancies in any consultant specialty, and Wales has been particularly hit hard. We wouldn't run a radiology service without a PACS, and we don't run a blood service without a LIMS. So in addition to safe turnaround, fast turnaround, the ability to push these digital images for second opinions around the world to get a better and more accurate diagnosis is one thing. The use of AI in reporting already live in some parts in Wales in prostate cancer, and the Royal College of Pathology training requirement that you will not be able to have trainees unless you have this. So it's a vital part of the architecture to deliver self-help services in Wales.
Thank you, Ridian. Rowan, and then we better move on.
Yeah, thank you for that response. And I realise it's a difficult challenge. I think, you know, we know what our priorities are, and I just think bringing it back to why it's important to patients is so much part of building that investment case. And the second piece is not to lose, you know, the progress we've made in the first third in the fundamental architecture that is going to allow us to be more nimble. Yeah.
Okay, thank you, and thank you, Ivan, and I'm sure again all the team responsible for sitting behind the report that you've presented. We're asked to receive and note that report, which I know the board will be happy to do. If we move then on to item 5.5, the finance report, and I'll hand over to Claire.
Thank you, Chair. I'm going to skip through a series of slides, which I think Jenny is going to flash up. If you move on to the next slide, I'm going to cover four main areas. The first of which is the financial challenge. So if you move to the next slide, Jenny, that'd be great. The second bit then will cover the performance as at the end of October, and some of the key assurance diagrams that we'll show in there. I'll then give you a bit of an outlook into the headline financial challenges that face us for next financial year, and then highlight some of those risks and opportunities financially within DHCW. So if Jenny could move to the next slide, that would be great. And the next one. So to enable us to do this analysis, I've looked at the performance against the budget for this financial year, and I've divided it into some key areas. One that looks at our core services and the core DHCW performance. I will briefly touch on COVID and our activity around COVID and the financial position, and then obviously touch on the Digital Priorities Investment Fund, which will show our pipeline, Rowan, and some of the, and I'll map some of the initiatives and where they sit. And then I will highlight what the outlook looks like for next year and some of the challenges that we've discussed through the presentations this morning. So if we move on to the next slide and then skip on to the next one. So as we were aware in the previous board and throughout January, it was became evident that the NHS Wales financial challenge was heading for a sort of a deficit of around about £648 million. Each organisation was asked to propose savings challenges from 10 to 30%. And following that, the Welsh Government announced a recurrent revenue allocation of 425 million with additional internal funding, which took it to 460 million, which meant that with that additional funding and with the 10% savings plan, the NHS in Wales could achieve a controlled overspend position of 123 million. The important part is really about how they've allocated that funding, because that funding is recognising the COVID legacy. It's also taking into account inflationary pressures, and in particular, the energy pressures that we've all seen over the last 12 months. So if we move on to the next slide, I'll then show you, well, what has DHCW done to contribute to that financial challenge. And before the year end started, we recognised that we were suffering energy and inflationary pressures. And if you recall, we actually wrote an accountable officer letter that indicated that we needed that we were struggling with a 1.9 million challenge throughout the year. We added that to our original savings plan, which took our sort of baseline savings target for the year to 4.2 million. So following the interaction with Welsh Government in July, we as an exec team went ahead and found additional savings. Of that, within our core, those equated to about 0.7 million, which took then our total internal core savings to 4.9. We then worked with other funding streams that we've received where we don't have direct control of, and those included our primary care colleagues and our COVID partners, but also the Digital Priority Investment Fund. And we identified another 3.3 million of non-core funding. And going back to Rowan's point, so where was the squeeze, and where will we see the fallout from that squeeze? And I hope what we've tried to do is minimise the longer term impact of that squeeze, and we focus those within that 3 million. There's 1 million in COVID, and you'll see in the subsequent slides how we've generated that because of a fall in activity, and therefore on the longer term there is minimum impact, but also additional savings from our DPIF related schemes. And most of those came from our two big programs, which is the NDR and the DMTP. And again, they work through that to do a quality risk assessment. So I think for the current pipeline and the impact, actually the decisions that we've made to support that will have minimum long-term impact. But equally, we have obviously done our half-year deep dives to understand what our overall financial position and outturn is looking like. And we had submitted additional funding for our central data centre migration and also for the SEAM that we talked about this morning. So again, within that, because of the the half-year position, we have taken the view that we can absorb those into our overall position for this financial year. So that gives you a flavour of where DHCW is, but also where the overall NHS position is. So extremely challenging from a financial perspective. So where are we then? So if we move over, skip across the next slide, and just to summarise what I'm going to talk about. So if you took to this one, thank you, Jenny. We are still confident that we are going to achieve our financial targets for this financial year. If you look at our run rate, which does fluctuate and is influenced with deeper spend, you'll see how we look to achieve that. We've got, as you can see, quite an aggressive savings delivery, but we have now integrated that. And if you look at our savings position for the month of October, you'll see we're ahead of plan in terms of our plan on deliveries. That aside, we shouldn't lose sight of the fact we do still have an underlying deficit. We brought that forward for 1.3 million this year, and obviously we will have to carry that forward into next financial year. So that will be one of the impacts that we look at going forward. But we do have internal mechanisms to control those costs. So we have 4 key mechanisms, and we review them as execs actually on a weekly basis. The scrutiny panel, which looks at our recruitment and validates approves the recruitment processes to our key areas. We have a capital and non-pay group. Sarah Jane leads our strategic resourcing group, and we also have an exceptional cost forum, and this has been really targeted around about areas of cost pressure, in particular things such as energy and also some of our key ICT contractual costs. I will then touch on the financial pressures for next year and touch on some of the risks which actually reflect the system risks that we're seeing overall. So if we move to the next slide, please, Jenny. So the overall position looks very green, which is why I'm confident we will deliver this year's financial position. Our overall revenue position at the end of October was slightly behind plan, and we had slight underspend, and that was actually lower than the previous month, but we are looking to break even. Our capital position, again, broadly in line with plan, slightly behind where we thought it would be, but no, not materially. And the public sector and cash balances, again, not much movement there. And there was a bit of a movement in cash balances, but nothing of note to concern ourselves there. So let's have a look at our run rate. I'll move us on to the next slide. So this shows our monthly spend position. So we're looking to spend 163.4 million this year, and to date we spent 91 million of that. And the dark blue shows the pay, and the light blue is the non-pay. And you'll see the fluctuations really happen in the light blue area, which really reflects some of our contractual payments within the Digital Priorities Investment Funding. And yeah, so it's looking pretty healthy. At the end of the year, you'll see a kick up, and that's us returning some of our savings into Welsh Government. The variations in the dark blue really reflect the backlog and payments that were made to staff in June and July. So if we move on to the next slide. So from a directorate perspective, you know, although the overall position is green and 132,000 revenue, there are some areas of pinch point as well as some areas that are offsetting that. And where we're seeing the pinch point is no real surprise, really. These are in the operational areas where we are seeing higher than planned. Well, we are seeing areas of pressure such as energy cost. The data center move now is incorporated into this area, and also some higher than planned labour costs. Offsetting that are underspends in strategy, primary care and board governance. And again, all of those relate to either vacancies or non-pay savings or estates savings. So again, going forward, looking at how we support operations to deliver their plan and get underneath that is what Sam and I are working on together with the team. Okay, if we move on to the next slide. So I've talked about savings a lot, and peeling that onion to see what's beneath that. This breaks down our savings plan from a core perspective. So we had that £4.985 million worth of savings. That's the annual plan. To date, we're looking to save 3.3. We've actually saved 5.2, so we're 1.8 ahead. And you can see we're ahead, really, because of the vacancy factor, but also of the additional savings we've instigated in order to offset the data centre move. So on the left-hand side, that shows where we are for the period of actual versus the plan, which is in light blue. The dogs are really excited about that, sorry. And you can see there, you know, we're making good progress across all of those schemes. Yeah, so we intend to achieve that. And that's why we took the decision at the half year to further support the data centre move. Okay, let's move this on. So I talked about COVID. Again, we had just shy of a £9 million annual budget for COVID, split between the TTP and the vaccine. You can see that actually, if you look at the TTP, the spend, it really reflects the decision to make to reduce the licensing volumes that we are now using against the TTP product. And if we look at vaccines, we can see that actually, again, we've had lower than planned levels of spend, really reflecting in the reduced costs around letters and text. And although we're forecasting a high volume of activity, again, there is likelihood that there may be potentially more savings to be made in this area going forward. So again, we actually have given back or plan to give back just over £1 million within the COVID activities for this financial year. So if I move us on to the next slide. Right, this shows us our Digital Priorities Investment Fund. So we've got over £36 million worth of revenue planned to be spent this year. To date, we've spent just shy of £18.5 million, with significant, you know, we're more than halfway through the year. So we've got quite a significant back end spend profile. Again, there was some minor underspends in both the NDR and the DMTP, and there was a slight pressure point within WCCIS, but overall we're in line with where we think it should be. Again, you'll see at the towards the end of the year, it's the top three programs where the majority of the end spend will be, in particular the NDR, and again we'll monitor those closely throughout the year, the remaining part of the year. So the next slide just briefly talks about capital, because I've focused primarily on revenue. A capital plan, we have our own discretionary budget of 2.6 million, and this year what dominates that spend is really the move to the data centre, and most of that is committed to date, and actually the plan is proceeding as we would expect at this point. The Digital Priorities Investment Funds, we've got about £15 million worth of spend planned for the rest of the year. Again, dominated by a few schemes, in particular the digital intensive care and the LIMS programme. Those are progressing broadly to plan. But similarly, as we've been focusing on savings for revenue, there were a number of opportunities to reprofile our capital spend for a few other programmes. And we've actually, in conjunction with those programmes, undertaken that activity. So that's, so Jenny, if you skip us on another 2 slides, that would be great. So that's really our performance within to the month of October. Looking forward then to our financial challenge, just when we thought it was safe, we're coming up to the next financial year. And again, I've sort of split it down into what I would call unavoidable pressures, and then our choices, our service and product choices, because we don't want to stand still. We want to grow and develop and underpin the transformation in Wales. In terms of our unavoidable pressures, what we are seeing is, and I've linked them into sort of 6 subheadings, is our service growth. The growth of our services is outweighs our growth in funding. And again, we are seeing some of our products, successful products, incidentally, almost come to end of life. And it's an interesting one because we're moving from what would previously be a capital investment replacement, and we're trying to translate that more into a recurrent revenue product-based delivery. So again, that will be something that we need to incorporate in our funding going forward. Digital inflation. So just like Health Boards and Trusts, we are seeing the impact of inflation. We think we've done the calculations and it's looking like at least an additional £1 million pressure next year, as we see, certainly within licensing, a consolidation within the market and a move to a less perpetual and more revenue-based licensing model. We've got some fantastic digital products such as the app and the NDR that we want to sustain in the right way going forward. Energy cost pressures haven't gone away, and again next year, looking at our data centers, albeit they are more efficient than they previously would have been, there's still an ongoing tail of pressures that we're seeing. And importantly, yeah, it's also about our responsibilities and our accountable requirements to keep us safe. So again, looking at our cyber resilience toolkit and plans, we need obviously to sustain that, and also sustain our role in our core services going forward in the appropriate way. So those for me are unavoidable cost pressures that we shared as part of the JET meeting, and also as part of our reviews with Welsh Government into what the challenges will be at the heart of DHCW for the next year. We don't want to stand still, and I know both Sam's and Ivan are keen to move us forward and actually developing our cloud and product adoption, and also improving our digital initiatives and toolkits and our products is going to be fundamental. And again, given the backdrop that we've seen, that those will be challenges for all of us, and we have to make the right choices, but those are the choices that we will be flagging up to Welsh Government as part of our IMTP. So I'll move us on to the next slide. So we've been as part of, and we'll see this in Mission 5 later on, obviously we want to develop a sustainable funding model for a digital organisation, and it's a challenge that I've been working on now for a while. To add clarity and weight to that challenge, we've partnered with the HFMA to look at what it looks like elsewhere and also what it looks like internationally, to really, once we've done all the calculations that we're obviously busy working on, to really add context and add weight to our ask in terms of Welsh Government going forward. So just for note really of some of the work we're doing alongside the day-to-day to really bring some clarity to a way forward. If we move on to the next slide, please. So finally, just to highlight our risks and opportunities. Clearly, digital inflation, contractual energy cost increases remain a pressure and remain a risk for us going forward, particularly as we go into the winter months. We continue to monitor that, not just from a usage, but also from a price perspective, and manage it as well as we can. Financial opportunities really is to work and find out what a sustainable revenue-based recurrent model looks like, and how does that compare with others to ensure that we set the right level of funding and have the right outcomes and benefits to justify that going forward. We are still working on our VAT recovery. Simon, I cannot give you a firm confirmation. We had a meeting earlier this month. We are still awaiting the outcome from HMRC. And then, yeah, it's really about how do we profile our vacancies to ensure that we get the right balance and address and support DHCW's growth, but at the same time recognise there's a challenge behind us. So I think there's a last slide that really suggest I want you to note where we are and where the system is in terms of the financial challenge. Note our position in October and the view that we are looking to achieve our financial targets for this year, and really to start to understand and appreciate some of the challenges going into next year for DHCW. And together as a team, as part of our IMTP with Ivan and his team, we're working through what choices we will have to make in order to maintain that position going forward. So thank you, Chair. I'm happy to take any questions.
Okay, if we just take the slides down so I can see. Okay. Yeah, so I was just thinking there was something on my headstone about, and we're still waiting for the HMRC to come back to us. Rowan and then David.
Just a little bit more colour, Claire, on the HMFA work. So sort of being able to articulate how much health systems spend on digital technology, I think is helpful. I would also observe that there is a piece here about, there's a huge opportunity cost of allocating capital to legacy systems, which is a short-term kind of hedging strategy. It's a short-term strategy because maybe investing in something new is just going to cost more in the short term, but it gives you value over the longer out term. So if you've got any kind of metrics in that study that's going to give you some granularity in their outputs.
So like any analysis, it's only as good as the data you can get. And actually, I have to say the English system has quite a detailed analysis of data. So we're currently under the data analysis and collection stage. So we're not in a position to say yet what insight that gives us. But when we have that would be helpful. I think you're right. We're in a transition, right? What we don't want to do is replicate capital investment in hardware, when actually what we need is a recurrent revenue product-based approach to financing. So how we deliver that and how we gauge it, because historically that was never the case, but we want to get the equivalent, is going to be the challenge. And the piece that brings that together actually is the value piece. And for me, that's how you mold them together to say, look, moving to this, to that, there may be a shift in requirement of funding, a level of funding, but actually the difference it can make is going to be significant. And I want to move the conversation from digital is a choice to digital is a necessity, but it's also an investment. And that's the bit that demonstrates the scale and the recalibration of the requirement in a way that's not unreasonable. It's in line with others. And that's the bit of work that we need to do. And as soon as we've got those numbers, I know Mike Emery's twitching and everyone else is excited by what it might tell us, good or bad. But actually that's the approach that we're hoping to get, the outcome we're trying to achieve.
Okay, David.
Thanks, Simon. Thanks, Claire. Claire, when do we expect the benchmarking report? Is my first question. Second relates to we're overperforming in terms of savings on vacancies, and you mentioned how we're dealing with prioritising where we do spend money and the like, which I think I took to understand as that's how we're managing getting to the end of the year safely. Is there any implication beyond that of not having scaled the organisation for the volume of work we've got coming next year? And then my last question is on the VAT recovery. Optimistically, we'll get it, but what's the consequence if we don't?
And I'll take a bet with you, David, that we get the benchmarking report before the HMRC response.
Possibly so.
So so I'll answer all three. So the HMFA work that we're doing, we're hoping to finish by this financial year. So by the end of March, we're hoping to have some indication at the end of January. So that's the time frame on that. Am I draining DHCW dry? That will mean that they won't grow for next year because of recruitment. I would say we are trying to get that balance right. Within that, there are areas of the organisation where recruitment, although with all the effort, it's difficult to recruit. So we're not actually constraining recruitment. There just isn't that resource to recruit to. And there are key skill gaps that that are coming to the surface that we're trying to address. And some of those key gaps, in new skills such as products, such as cloud, we are working with Woody to develop those skills internally and give that opportunity for our staff to shift into those skill sets. So I think it's a difficult one to answer, David. We're trying to assess the quality impact risk. And I know SJ and the strategic resource group are throwing everything at this. There are clearly some areas that we do need to achieve, and there may be more than one way of achieving it. And we're looking at each. What was the other one? I've missed one, haven't I? There was the
VAT. What happens if we don't get it?
So the VAT is an opportunity. So it hasn't been built as a certainty into any plans. So Having said that, if you are listening, HMRC, we would like to understand the position, because we do put a lot of energy in trying to justify it. And if it's an end game, then I'd rather my team work on something else, if I'm honest. But yeah, so Santa's coming soon, so I've put my wish list in, and let's hope we have a result before Christmas. But I don't know really. It's truth be known.
You should have stopped believing in Santa. Sam Lloyd.
Thank you. Just to add in response to the question that Rowan asked as well, we are looking at increasingly at the whole life costs of products and services, and then the options that kind of multi-year cost model then offers in terms of how they're delivered. So, for example, for our data center infrastructure, we're looking at the 5-year opportunities around transition to cloud. So, what are our major investment decision points around data center contracts or hardware reprocurement or software licensing, and building that into a multi-year model, and then understanding what that would look like if we were to transition those services to cloud over that period. So, we can start to, that then really starts to inform some decision making and starts to identify where there might be opportunities that we can find over time.
Claire, I got 2 questions, and I'm sorry if you answered these in your presentation, but I don't recall, have we had a formal confirmation from Welsh Government in response to our savings plans yet? And are we being treated the same as health boards in terms of the coverage for the unavoidable inflationary costs?
So we haven't as yet had formal confirmation of our savings plan, albeit we're working on the basis that there is an expectation we'll deliver it, and we've built those into our forward plans. So I would say that we are not unlike health boards and trusts in having exceptional pressures that we are finding very difficult to absorb, albeit this year we've managed to offset those with additional savings. So in our recent meeting with Welsh Government, I've raised the underlying unavoidable costs that we are seeing, and they have agreed to work with us to reflect those pressures as part of and looking at it in consideration with the other aspects that we've raised around our core. So we're awaiting confirmation of where that will be, given that they are also struggling with the financial challenges. I understand that we will get our allocation in line with health boards and trusts on the 24th of December. So at that point, my expectation is that going forward with the backdrop similarly to health boards and trusts, that will be reflected in our allocation. But until we've got, it's a bit like the HMRC, until we've got that piece of paper, it's not confirmed, but we're trying to work hard with them so they appreciate where we're at and what we're trying to do, and they are listening to that.
Okay, any other comments or questions? Okay, thank you for that. Claire, it doesn't feel like you're behaving like Santa, it has to be said. I mean, obviously this year is difficult, but we will get through. Next year is going to be really, really challenging in terms of all the things people have talked about around wanting to move forward, want to gallop, and wanting to use digital as a transformation tool. It's going to be really, really challenging next year. And it's helpful to have that early heads up on where things are likely to be, Claire. So thank you all very much. We'll break now for lunch. It's 12:38, so we will take half an hour. So that means we come back at 10:1, please. If people could turn off their cameras and mute, I'd be very grateful. See you all at 10:1. Okay, welcome back, everyone. I hope you were refreshed and had a good break. And we'll move straight into item 6.1, the corporate risk register, and I'll invite Chris Darling to present the corporate risk register. And I think you're probably going to bring in other exec members along the way, Chris, on specific issues. So over to you.
Yeah, thank you, Chair. Yeah, I'm going to present the corporate risk register. I'm actually going to cover 3 areas within this item. So I'm going to run through our current risk profile position as we are now. I'm going to then move to a presentation to cover some corporate risk trending analysis over the last 12 months. and just feedback on that work. And then that'll move us into the board assurance framework, where I will bring in exec leads for the relevant strategic missions and principal risks, just to update on their areas. So just starting on the cover paper, item 6.1, and the report, I've started slightly differently this report. I've incorporated Alistair's comments from the last board meeting. So you'll note section 3.3 of the report starts looking at risk through the lens of opportunities. So as Alistair rightly pointed out at the last meeting, there are a number of threats and opportunities that our risk landscape presents us. And just considering the opportunities from a digital and a health and care perspective, I've listed a few. So the growing importance of data in this sector, digital services driving service transformation, moving to cloud services, international technical and data standards, a shift from capital to revenue funding-based models, moving from program to product-based delivery models, automation and artificial intelligence, and patient empowerment and apps. I mean, that's just a flavour, but I think it's useful to frame the discussions that we go on to have in that context of opportunities as well as risks. So just to talk through our current risk profile position, we've got 22 risks on the corporate risk register at the moment, 14 of which are detailed in Appendix 6.1i, Appendix A. And I'm going to just run through some of the changes over the last 2 months since the last board meeting. So in terms of new risks, there's been 2 new risks approved by Sam Hall, so both in Sam's area. So the Choose Pharmacy 0329 DHCW maintaining the funding gap, and the second one 0330 WCCIS future program funding. So they're the 2 new risks that have come onto the risk register since the last board meeting. There's been 8 risks that have been removed. I'm not going to focus on these because I will touch on a couple of those in the risk trending analysis, but happy to pick up any questions on those. And in terms of risks with a change of risk score, there is one 0323, the cost for transition and ongoing operational support around the development of the NHS Wales app and platform of services. So I think it's important just to note that this one has had an increase in the risk score since the last public board meeting. Okay, so the last point I wanted to make on the cover report was just to say we have now moved the oversight of a number of risks that were previously overseen by the Digital Governance and Safety Committee to the Programme Delivery Committee with the establishment of that new committee. So all programme risks now and moving forward will have oversight from that committee. I'll move on now to the corporate risk trending analysis. I'm going to start with that, and then I'll move straight on to the Board Assurance Framework report. So Jenny, if you would be so kind just to get the slides up, and I'll work my way through those. Brilliant, thank you. So the analysis I'm going to cover looks at the 12-month period from the 1st of October 2022 to the end of September 2023. So a 12-month period looking at those corporate risks that have been on our risk register. So if we move to the next slide. So just a bit of context. When we established, we set out a committee assignment approach. So all corporate risks would have oversight by the relevant committee as part of the risk management strategy that was agreed by the board. And all corporate risks are added to the risk register with the approval of the relevant executive lead. So the 2 new risks, as I illustrated earlier, approved by Sam for her area. And as part of the work plan this year, we built in this stock take where we would look at the past 12 months, which we did last year following the suggestion from Rowan. So we've carried it on to this year just to take stock of where we're at. And over the past 6 weeks or so, the Audit and Assurance Committee and the Digital Governance and Safety Committee have reviewed the risks that have sat on their areas and had a look at some of the analysis. So if I move on to the next slide, we'll just start by looking at what's changed over the past 12 months. So we started on the 1st of October with 26 risks on the corporate risk register. And in that 12-month period, 33 have been escalated and added to the corporate risk register. And in the same period, 34 have been removed. So I think it's just showing that there's a fairly good process in terms of the dynamism within the process. New risks are coming on, older risks are being mitigated. But then we've done some analysis as part of this, and the next slide just starts to illustrate where we haven't been able to manage some of the risks as effectively as perhaps we would like, to mitigate them or to turn them into opportunities. So over the last 12 months, 11 risks have remained on the corporate risk register during that period. Now, there are a number there marked as private. I just want to give some assurance that they are considered in mainly the Digital Governance and Safety Committee in the private session of that committee meeting. So the detail isn't included there, but the other risks that are marked as public are included. There's two risks in particular that across the two committees we've had a lot of discussion on over the last two committee meetings because they have been on the risk register for over that 12-month period. So the first one is 0237, new requirements impact on resources and plan, which is overseen by the Digital Governance and Safety Committee. And the second one is 0259, staff vacancies. So just picking up the first one, this has since those discussions been downgraded as a risk. New requirements impact on plan. This risk initially came out during COVID when there was a lot of competing and changing requirements to respond to the pandemic. And it did morph into a risk around ongoing changes or requests for new things. The IMTP process over the last 12 months has, I guess, been strengthened to the extent that we're very explicit now about where things are funded, where things are not funded, where things we want to do and are on our list to do, but we require additional funding. I think Claire's presentation earlier illustrated some of that. So it's downgraded to the extent that we have a clear process and we're cognizant of what we can and cannot take forward within the resources available. That's not to say it's not still a factor that we consider, but that had a lot of discussion prior to downgrading. The second one, 0259, the staff vacancies risk. So this is one where Sarah Jane's the executive owner for that risk. And again, had a lot of discussion around that risk and the role of the strategic resourcing group overseeing workforce gaps and ensuring staff recruitment or contractor capacity are in place to allow us to deliver. And I think, again, the current context allowed us to downgrade that risk. It hasn't been taken off the risk register. It's still very much a focus of the strategic resourcing group, I know, but it has been downgraded now. So those are two that I particularly wanted to pick out. The other risks that have been on for 12 months have had a lot of focus and a lot of discussion. So if we move on to the next slide. So this slide shows us that the majority of risks have had oversight and scrutiny by the Digital Governance and Safety Committee. So the table at the bottom, the green line, shows the risks being overseen by that committee for the last 12 months. It peaked in August with 23 corporate risks. The Audit and Assurance Committee peaked, the blue line, in March with 12 risks they were overseeing. It has dropped slightly since then. And as mentioned earlier, a number of risks, 7 have recently transferred from the Digital Governance and Safety Committee to the Programme Delivery Committee. So that should give more of an even split across those 3 committees of corporate risk oversight. If we move to the next slide, and this is just coincidental actually, but on the 1st of October, there were 26 corporate risks. And at the end of that 12-month period, on the 30th of September, there were also 26 risks. The graphs on the left just show the the variation and fluctuation of critical and significant risks during that period. There's no, we haven't been able to see any correlation, but it's useful to have some of that analysis. And if we move on to the next slide, just going to pick up. So discussion at the Digital Governance and Safety Committee 4 weeks or so ago, I've tried to pick up David Selway's feedback when reviewing this information. So David, and I don't think we've fully addressed it, David, but we've tried to do a bit of analysis that you asked us to look into around the risk trending, to look at the last 12 months compared to the previous 12 months and what it tells us. So in 2021-22 compared to 2022-23, we saw similar number of risks by domain, and those were dominated by, as you can see in the top right-hand box, the financial risks and the security risks. So for both periods, or the last 2 years, they have been our highest risks by risk domain. Comparing 2021-22 shows more risks being closed more quickly, so within 1 to 3 months compared to the most recent period, but we did close significantly more during the most recent period within a 4 to 7 month period. And there were no trends that we identified in terms of time of year when risks came on or came off. So this is extra work we've done more recently, and we'll continue to do a bit more analysis on this. So thanks to David for instigating that thought process in terms of looking at the previous year. So if we move to the next slide, and we've started to map corporate risks to the strategic missions as well. So the fewest risks we've got assigned to principal risks and strategic missions with the highest risk appetite. And I think that's quite reassuring. So where mission 4, we've got an open risk appetite, and we have the fewest number of corporate risks, and mission 3 and 5 we're moderate. So we're reflecting that as a board, we're agreeing for those areas we'd expect to see fewer controls because we're empowering opportunities to be taken. But areas where we're more cautious, so strategic missions 1 and 2, we take a cautious risk appetite, and that is reflected in our corporate risk register in terms of the risks falling into those domains. So this trending analysis, I think, is a good opportunity to challenge ourselves as an exec, as a board, about where risks are becoming long-standing. Are we doing what we can and should to mitigate them and to manage the threat or to realise the opportunity? So I'm going to move from this slide, hopefully seamlessly, into the next slide, which starts the BAF dashboard. And I'm going to very quickly go through the first few slides to leave time for each of the exec leads to run through their areas and just comment on progress and plans over the next period. So this is a 6-monthly update of the board assurance template. There's been no change to RAG status for any of the missions, so they're all amber at the moment. And some of the key controls and assurance changes are summarised in this slide. If we move on to the next slide, just a reminder of our risk appetite, and that as a board we've agreed that DHCW must take risks to achieve our strategic mission. So we know we have to take risks. We're doing that in a controlled or agreed risk appetite that we've set out. So on to the next slide, we'll just see a summary of our principal risks as they're articulated. The current risk scores are set out in the middle. And then the target risk score that we're aiming to get to is set out on the right-hand side. And the next slide just demonstrates that the majority of the principal risks, we're looking to reduce the likelihood of the risk happening in order to give the strategic mission the best chance of being delivered. So if we move on to the final slide, I'm going to comment on. So this just gives a summary of the board assurance position, the current risk appetite, which exec leads might want to comment on for their areas, and the assurance of amber across the board at the moment. It feels quite brave, doesn't it, going to green or red, but so it's currently amber for the 5 strategic mission areas. Now, the one thing I don't know is whether Ivan has returned. I know he had to drop off because I'm planning to hand.
Yes.
Yes, excellent. Okay, so I'm going to hand over to Ivan, and then I'm going to ask if Ivan, you can hand on and colleagues can hand on until we get to the last mission, which is Claire, and we'll conclude there, just so we're not going back and forth. Thank you, Ivan.
Yeah, thank you. Sorry, my camera turned off for some reason. So if you can go on to the next slide then, please. That shows the first mission. So the risk in this area being that the platform that we have, the infrastructure and the data and the systems isn't as robust and secure as it could be. So that's holding us back. And also it's not as flexible as it could be. So that makes it more complicated and slower and more expensive for us to develop and to provide services. So there are the regulations and the checking looks at those areas. And firstly, I should mention the status. So we've confirmed that we should remain on amber in terms of risk. And that's because we do have a secure platform, but we also know that we'd like it to be a more flexible and open platform. And so in that respect, our eagerness for risk has to be very careful. And so we have to be extremely careful and vigilant. In terms of the progress, in terms of the action plan for the first half of the year, the headings is that the NVR platform is live and has been live since August, and the new APIs have been published, and that they are being tested with partners, and the government has written to the NHS across Wales directing them to use the fast standards, and that we have begun on the work of consulting on a WASB Code of Conduct, which enables us to share data across the public sector for health and social care. All of these, as we know, are things that we need to undertake to make sure that we have a flexible platform which enables us to be able to transform more quickly. And I think that's positive progress over the past 6 months. In terms of looking forward to the coming 6 months, we've got more work to do. Initially on developing our resources on the cloud. So moving to a more modern infrastructure, there's a strategy that drives that work, and we will continue with that work. And also we need to make progress on the data promise for Welsh Government. And this is the framework which will enable us to share information safely and securely, and also with the legal rights that we need across this system. And we are continuing to have conversations with government around that. So I'll now hand over to Sam Lloyd.
Thank you, Ivan. So on to mission 2, if we could move to the next slide. Thank you. So this is to deliver high quality technology digital products and services. The principal risk associated with this mission is that if we do not deliver those products and services to a high quality, then the ability of health and care partners to deliver and modernise their services is compromised, which will potentially result in less effective, less sustainable care that could cause harm and will not meet the expectations of patients and professionals. There's a risk appetite that we've set in this space of cautious. Obviously, the impact of changes in this area could be significant. We're processing a lot of patient data in this space. Our services are used in direct patient care, so we need to be very careful in how they are managed and changed. But that said, we haven't gone for an averse risk appetite because it is necessary to move and change and make progress in this space. There's a particular quantity of our major programs sit inside mission 2, so there is a lot of activity, and that does mean we need to incur some risk in order to make progress. Overall status of this mission is amber. I think that does reflect the impact of many of the programs which are underway in this space. Some of our biggest pieces of activity, such as the laboratory informatics system procurement, the radiology informatics system procurement, the laboratory information management system, iCare, some of the other things that we've talked about today are within the scope of this mission. Some of the specific risks that are associated here we've talked about already. So the Choose Pharmacy funding gap, the WCCIS future programme funding, we've covered. The technical debt accumulation risk also sits under this mission. We've done a lot of work to reduce our overall infrastructure debt to replace legacy hardware, to upgrade our data centres and so on. But really the next major phase of work that we face in that space is to modernise our application estate and to move towards a much more holistic national architecture. So there is a significant amount of work to be undertaken there. Key progress over the last 6 months, as I've mentioned, LIMS 2 and RISP have been transferred in from the NHS Wales Collaborative, and we've got delivery plans which are currently on track. We recently went live with electronic test requesting for a pharmacy under GP practice as part of the Digital Medicines Transformation Programme. That was a significant milestone in that programme, which was met with some fanfare. Also, I'm thinking about how we structure ourselves in order to optimise our delivery. So I've started a consultation process within operations to establish the new top-level leadership structure that I need to strengthen capabilities in areas such as DevOps and cybersecurity and digital delivery and architecture and so on. And so the forward look is really around developing the action plan and progressing our target operating model, which is going to bring those changes into fruition and help us build the digital capabilities that we need in order to keep moving forward over the next 2 to 3 years. Thank you. And I'm going to hand back to Ivan for mission 3.
Thank you, Sam. As you know, the 5 missions that are included in the framework, the risk framework, are the same missions that we have in the IMTP. And we also use those first three especially as a way of conveying our technical performance. So the platform at the bottom, and then there are digital services and digital systems that are then built on the platform. And then in addition to that, the interface where users come into contact with those services. And so that's the risk in this area. One, that users don't use those things that we provide for them. And it doesn't matter how robust the technology that we provide, unless people use it, then it won't give value. And also, it doesn't matter how robust it is in terms of as a data, unless people input information into it, unless people read information from that data platform, then that information is of no use when providing care and health. So our risk in this area is that not enough information is going in and out of that record, or not enough users are actually using the services that we provide. We are working hard in this area. In the 2 portfolios, is working with professional users and also working with the public users. We've looked at the risk and the status of the risk, and this continues to be at amber. And our appetite for risk is somewhat higher here. We are moderate rather than being cautious, because we have greater freedom in the interface, in the presentation layer, to make things a little bit quicker. And you can see that in the way that the app has been developed, working closely with users, going through the metered phases, etc. So that's one of the main headings over the past 6 months, the NHS app. And then we're looking at this going into April. And over the past 10 weeks, we've engaged with over 200 GP practices across Wales. We're hoping to complete that process by March, so that we can then speed up the use of the app via those initial care services that we provide, and also the nursing documentation as well. And that's for adults, and that's moved now into a live service and has now moved into one service across the whole of Wales. So we are now working on the Welsh clinical nursing records, but that's for children rather than adults. So there's quite a lot of work to be done there. What I'd like to draw out of this as a priority over the coming next 6 months is the work that we are doing with users. And under this theme, this is where we're doing the most work and closest to the users of this system. And we've put a number of methods in place in order for us to be able to do that more effectively and intensively than what we've done previously. So we are keeping an eye on these risks. The appetite is somewhat higher here, and we strongly emphasize that we are working very closely with users in order to provide what they want. And the main progress over the past 6 months has been via that service, and it will continue to be important in going forward. And I'll now hand over to Rydian.
Thank you. Sorry, my camera's a problem. I've switched off and switched back on. Can you hear me, Chair? You can. Okay, thank you. So mission 4, drive better value and outcomes through innovation. This is the only mission that we have which has an open risk appetite, and this reflects that we're willing to take more risk to drive value and outcomes through innovation. Key progress over the last 6 months. The R&I governance arrangements have been established and are starting to work and have been embedded. We've engaged a significant amount of engagement and building relationships with partners. We've undertaken the pilot phase of the secure data platform, and the health intelligence portal is now live and accessible on the website. So that's good. The informatics and analytics strategy has been approved today. So that's progress. So the forward look is making that strategy work, continuing to embed the R&I functionality and activities that we're involved in, to develop the proposals around the find, recruit and follow-up service. So this is to encourage delivery of more clinical trials across Wales. We continue to develop our data request service. That's for operational purposes, obviously, digital transformation and improvements. We continue to expand our offering in the Value in Health program. We have very close alignment with them, including things like PROMs into our products. And of course, these areas continue to have assurance and oversight by the DGNS committee. Thank you. I'd like to hand over to Claire.
Thank you, Rydian. And I leave the best to last, which is mission 5. And the reason I say that is this is one that I could talk on an hour on all the wonderful activities that we're doing to support the fact that we're becoming a trusted partner. And actually it's about high quality, inclusive, ambitious organisation. And I think that reflects the team that underpinning all the work that's going on underneath all of that to deliver the key controls and the key action plans and frameworks to do that. Now we have a moderate risk appetite. Actually, we have quite a varied risk appetite, I think it's true to say. We have some that is quite open, we have some that's quite risk averse. So it's a happy medium, I think it's true to say. And we are currently amber. We have been green, but I think it's because this really reflects a journey that we're on. And although we're sort of more than halfway through the year and we've achieved an awful lot, we've still got quite a lot to achieve in the remaining part of the year to mitigate some of the risks. It's really difficult to choose some highlights, but I know that we have, and it's so I would say I'd reflect on the fact that we've done quite a lot of work on the digital workforce review, and we're working with our partners, particularly in FedIP, to develop the roadmaps and development plans underneath that. The strategic quality plan has been approved, and obviously the EDI network is established. I know many of you participate in that. The digital inclusion work group has been established and progress is made. And obviously we updated the digital inclusion plan at the March, we updated at the March SHA board meeting. We've done a lot of work on digital maturity with the class and HIMSS work. And Helen actually shared that with chief execs very recently. And we've done many more, to be fair, that I'm probably not doing justice by summarising some of those. Looking forward, it's about really embedding a lot of the plans and frameworks that we've done. We are doing a lot of work, as we already alluded to in my previous slides, on sustainable funding and what does that mean. We've done a lot of work in developing the benefits framework, and actually now it's about the benefits register and being able to demonstrate the outcome of the measures. Nadine's done some fantastic work on stakeholder engagement. She shared that with us yesterday, actually, in sharing that feedback and really sharpening our engagement processes. And obviously we've been developing the digital portfolio office. So Yvonne and the team have been working really hard to really embed a portfolio management approach. So that's one of many of the activities that are going. We met recently to review our risk score and whether we wanted to change it. And actually, whilst we've achieved quite a lot and we've made quite some progress, I think the group felt that actually we wanted to keep it the same. There were some risks in some areas, but actually they were ahead of plan in others. So again, we took sort of a mid review in that. So yeah, so that's mission 5 update.
Thank you, Claire. If we take the slides down, because that concludes the run through. And Simon, I'll hand back to you for.
Thank you, Chris.
Any questions?
Ruth, you want to come in first?
Thanks, Simon. Thanks, Chris, and thanks all for those updates. Two comments. Firstly, I think the Programme Delivery Committee is going to prove really helpful for us in terms of that additional level of assurance, particularly from the perspective of Audit Committee. I know that I've always felt so many of our risks are influenced by our big programs, and it's not always been clear to me how we get that proper oversight of some of that going on. Notwithstanding, we've had some very good updates at Audit and Assurance, and I know that digital governance and safety have been on the case with this as well. So I'm really pleased that we've started down that route, and I think the first PDC was very helpful. And then I put my hand up in mission 5 because I'm like Claire, I love mission 5. And Claire, you're right, you didn't do justice to all of the work that has happened on mission 5, but what has done justice to the work that's been happening around number 5 is some of the deep dives that we've had at Audit Committee recently, where we've been able to get it under the skin of some of those actions that have been happening. It strikes me that throughout the whole of this meeting today and previously, there's been an ongoing conversation about our dependencies around staff vacancies and around the digital workforce piece. Particularly, it has such an impact on our finances and our ability to deliver. So I did wonder whether we were due time for an update on the digital workforce strategy piece at Audit, probably, so we can see where we're at, given I know the amount of work that's gone into that. Thank you.
Thanks, Ruth. Chris, do you want to come back on that at all, or invite someone? Then I've got a question from Marion.
Yeah, well, just to concur with Ruth, from the Programme Delivery Committee perspective, I think in governance terms, it gives us a second line of defence of assurance that we didn't have previously, did we? So that's helpful to have in place, and certainly happy to work with Sarah Jane and Marion to look at a deep dive on the digital workforce element of the BAF and bringing that to Audit Committee.
SJ, do you want to come in on that point?
Yes, please. Thank you, Chair. Just for assurance, Ruth, we are looking at sort of our structures moving forward about how we can best support all the new programmes, existing programmes, and with a forward look. And with the RATS committee happening in the next couple of weeks, there will be some more detail within that, and that will come out through my structure about the work with the Fed IP and just the ask probably for next year, really, about how that's going to support us, how we can support the work on the DDAP framework and the workforce review, and indeed all the other things that are going on in terms of the workforce redesign and all the organisational change programmes. So hopefully that will be a really good opportunity to tease out some of the detail of that and get that into sort of, good measurement, and hopefully, bring forward some questions which would be really helpful for wider understanding.
Thanks, SJ. If I just read out Marion's question. She's asking, with regard to Strategic Mission 3, could you please, I'm trying to remember who that would be. Could you please elaborate on DHCW's approach to developing, I thought it was you, Yvonne, to developing user research and research design? We heard earlier that clinical input was key to develop the unscheduled care dashboard. It would be helpful to hear about how we might strengthen clinical input into DHCW products and services.
Thank you, Simon. I'll invite Sam Hall in as well. I think she's our champion for user-centered design and setting up a centre of excellence, or working on establishing a centre of excellence. I'll just comment on the NHS Wales app and maybe on the unscheduled care dashboard. So we've always done a lot of clinical engagement. Our major programmes are very strongly clinically informed, and we go out and we spend usually up to a year engaging with clinicians to ask them what it is that they want, and then we try to reflect and incorporate that into the specification requirement for whatever it is that we're purchasing. And an example of that going on right now would be Digital Maternity Cymru, for example, or some other programs. We're trying to evolve that, I think, into more of a user design framing, which is not responding to all of the wants of all of the users, but instead using that as the research that you need to inform the design that best meets the underlying needs or demands of the service and of those users, informed by what it is that they tell you that they want in a more dynamic sort of way. And certainly on the NHS Wales app, we've seen lots of that, first through user workshops, then through private beta, and quite a structured, task-oriented. We had 790, I think, users, but every 2 weeks they would be given tasks to work through. We'd seek feedback from them on their feelings around those things. A lot of that was reinforcing what we thought anyway, but some of it was challenging and questioning and suggesting new things, which we then responded to through new features. And we've got active feedback, and we've got active user satisfaction on the app all the way through. So that is broadly what we've got for the unscheduled care dashboards. We've got a senior user group, that, live users of the group that give us feedback through structured mechanisms. So we're trying to evolve all of this, and we're doing it in Mission 3, but we're doing it across all of our other products and applications, because it's a really important part of our organisation, and it's in the design standards, it's in the Welsh Government data and digital strategy for health and care and various other things. So hopefully, Marion, that answers some of the questions. Sam, I don't know if there's anything that you want to add about Centre of Excellence or about UCD in general, because you've got a deeper knowledge of it than I have.
Yeah, of course. So we have a working group looking at developing a Centre of Excellence for user-centered design. So that isn't to say that we don't do that already throughout DHCW. There are lots of people doing really good research and designing and providing services and products for people. However, what we really want to do is professionalize that and standardize it throughout the organization. And that means the people that are already engaged in that, working with them to upskill, get them some certification, get them embedded in the right places so that they have the biggest impact that they can, and use their professionalism to really help us drive our products and services forward. And then to spot those gaps where actually we might not have some of those really well-honed skills. So things like content design, for instance, which is a profession in itself, how to get how to make the best message and get that message to the right people in the right way, and how you use that in a digital world. And so some of these new kind of more emerging professions, we need to get those established within DHCW as well. So that working group has been going now for a couple of months. We're already looking at pilot options around some of the projects we might take forward with them, and also working with people in the clinical directorate who've already started a lot of work on standards around user interfaces and accessibility and usability. So it's a really exciting piece of work, actually. We started with about half a dozen people interested, and I think that working group grew to 20 people really quickly who said, actually, this is something we really need to know more about and want to get involved and engaged with. And so we will be bringing a report, I think, back at quite soon in the new year around that work. But it's very exciting.
Thank you, Sam. Thank you, Ivan. Any other comments or questions on any of the elements of the book? Okay, so we're asked to receive that report, aren't we, Chris? That's correct. Okay, if I move on then to 6.2, the Integrated Organisational Performance Report, and it's back to you, Ivan, to introduce this item. You're on mute, though.
Yes, thank you. Sorry. So it gives me great pleasure to present the Integrated Organizational Performance Report. This document goes side by side with the next item, which is our half-year performance plan against the IMPT, but I'll take them as two separate items. I've already mentioned the first part, which is the score, and then I'll present and ask SJ to mention the section, and then Sam Lloyd. Well, she will hand over to Sam Lloyd. And then any significance really is towards the end of the document. So in terms of the scorecard, hopefully you can see, and I think it's really useful actually, how it shows that over the past 12 months, the status of these various things on the scorecard has changed from one month to the next, and it's of a great help to us actually. There are 4 squares which are currently amber. Well, 2 of them, which I think Sam will pick up on, those that have come more regularly, more consistently over the past 12 months. And if there are any specific questions about that specifically, then I ask you to ask those after I've presented. So moving on to the next page, these are the headings that we included IMPT on the main programs against all of the portfolios that we have that are trying to show at a very high level some of the most important milestones that we have. And this year we've used colors to show where we had resources and where we didn't have any. So there are 2 things that I'd like to draw out. So firstly, the main story on the halfway point is that we're continuing to succeed to achieve against the majority of the plan, despite the financial pressures, despite the recruitment challenges that we have. We are still seeing that our teams are delivering against the timetable and also relatively against the timetable. And also there are pressures in the system in terms of some milestones are slipping into the 3rd and 4th quartile. But on the whole, we are continuing to attain against the majority of our integrated plan. And I think it shows that we've been far more disciplined in preparing the plan last year. We hadn't put too much into it. We needed to be clear about what we were hopeful that we were able to achieve. And the extra pressures that have come through during the year have had an impact, but haven't had too much of an impact on our attainment. But we are keeping a close eye on this. You will also see that there are some color changes in some of our milestones, and one of them is being the radiology risk and the DMPC. And when we agreed to the IMPT, we weren't really sure about our finances for the following year. But we do have that assurance now. So they were yellow, but they have now moved to green. On the other hand, when we agreed to the IMPT, we'd expected that the government would give us some finance on the cyber plan and on moving the data center. But the question that Rowan brought up before lunch, actually, it's turned out that the government haven't been able to provide the finances for those plans, so they've turned yellow. And so we've decided to prioritize our core funding into those activities. Now that assures that these important things happen. And cyber and moving the data center, things which are extremely important to us. But they don't deliver additional value. They don't develop new product, and they don't develop new systems. So you can see in that plan that we are moving our resources into things which keeps the lights on and keeps the system safe, rather than developing new pioneering things. And I think that's a pattern which will become more and more obvious. And the last thing that I'd like to mention on this slide, the Welsh Intensive Care Information System, not the Welsh Community Care. There are two WICAs. So the WICAs is the one that goes in our intensive care. And the timetable was to go live last week in the Aneurin Bevan Health Board. The supplier has provided the system to the timetable that was given, but it's taking longer for the health board to test the system, and the user acceptance testing, that is checking that it's safe and that it's performing as it should and that it's doing what they want it to do. So that process has taken longer than what had planned. So that service has not yet gone live. And that's having an impact on the programme timetable and likely to have an impact on our finance timetable. So we are working very closely with them currently. Myself and Michelle and Claire and Helen and the programme team have discussed with Aneurin Bevan in order for us to find our way through that programme over the coming 6 months. And I think we've reported elements of that to the PVC some weeks ago. So that's it from me. Then I'll now hand over to SJ for people and institutional development. So SJ.
Thank you, Van. Yes, and some good messages in this report, which is really positive for us all as an organisation. So I'll start with the sickness figure, really, which is incredibly low. And I think hopefully that provides a little bit of assurance with some of the themes that have come out through other conversations during the reports today, is that we've got some vacancy challenges. And obviously in terms of monitoring sickness, it hasn't spiked, and where we do have some hotspots, we do look at resourcing that differently or independently as much as possible to support staff in posts where perhaps there are some further challenges, and just to provide some further assurance. Obviously, some of those gaps are filled with contractors and agency staff, and we're working through the work stream. So it's a bit of a combination of efforts between Claire's team in finance, the commercial team led by Michelle, and my team in people and OD as working through that very much with people at the heart of that, and making sure that we are looking at prevention and well-being, not just dealing with the consequences of sickness. I think the other thing just to mention is we've increased our target in terms of statutory and mandatory training, which is great, and that's been a huge push by all of my colleagues as well, working through with the teams and their directorate managers to drive that forward, and that's been brilliant. Just to note, again, for an additional assurance piece, Michelle in commercial and I have worked through the external resourcing as well. So we've started to have a think about, and it's being implemented this month, the external resources that are coming through from agencies and contractors, making sure that elements of some of the internal training, whether it's corporate induction, local induction, or some of the statutory elements of our training, they're also doing as well. So that's been more formalised now through a piece of work that the commercial team have taken forward. And although it won't be documented anywhere, because if they're not on ESR, it won't get documented in the figures, but it's just another feature that I think really strengthens the security aspects and the development aspects in terms of how we're sort of looking at all the resources that are being utilised. And just finally, on appraisals, again, we've moved the position upwards, which is really positive. But just to note, we won't ever get to 100%. Obviously, we've got secondments out, people that are long-term sick and maternity. So some of that is just a bit of a given that we've done really well, and probably we've got to the best position ever actually in that regard. So yeah, really great achievement by all the teams and all the managers across the whole organisation to drive that forward, and to make sure that we've got the audit trail, that everything is actually listed so it can be reported on back. Because I think actually a lot of them had been done, but in terms of documenting it on the system, that probably just needed to be a further exercise so we could report that back confidently. And yeah, so some really good stuff, and happy to take any questions.
Thank you. Yeah.
Yeah, thank you. Just a few points on operational performance that I would like to bring to the board's attention. So on page 11 in the report, we're now reporting major incidents by service over the last 6 months. So we can see which of our services are consistently being most impacted by major incidents. And the graph shows that there are 3. So the radiology information system is the highest, with 10 major incidents over that period. So that's a distributed system which is hosted individually across the health boards, and DHCW doesn't actually host. So that system is, or those systems are potentially subject to local issues and incidents, which is probably what accounts for that number. And then the next 2 are the Welsh Clinical Portal and the Welsh Patient Administration Service, both of which are very large, high-profile systems that we support, and they're probably the 2 most complex services that we provide, with a very high degree of interconnectivity between a number of our other systems. So there's quite a complex web of integrations in place, which means that those systems are quite vulnerable to outages across other parts of our infrastructure, which accounts for the high number of major incidents that we see there, and possibly points to some architecture work that we can undertake in the future. Coming to the major incidents per month chart, so we can see that we've had a downward trend in major incidents over the course of this financial year up until September, where we had 2, which was I think our lowest number that we've had. But then we've seen quite a sharp spike in major incidents this month. Some of those are due to a number of unconnected circumstances, but then some of it is down to change activity. So we are in the process of commissioning the new network for the data center move. We're at a point of quite high risk in that program where we're having to undertake major infrastructure changes, some of which have caused service incidents, and we've had to back them out. So we're in the process of looking at our approach there, making sure that we're reviewing our change management processes and understanding what the impact of this is on the data center move. But we have seen a number of incidents relating to that. Overall, though, our availability does remain high, so we are at 99.973% for October, which is above our 99.9% availability. And one other thing just to add is that we did undertake an external review of one of our major incidents in October, which has come up with quite a number of helpful strategic opportunities for us to improve our handling of major incidents. So we'll be looking at those and building them into our operating model design work and service management review, which is about to start. Thank you.
Okay. Sorry. Is there anything else you wanted to cover now, Ivan?
No, but I welcome questions either for myself or for other members.
Okay. David and then Helen.
Thanks, Ivan. Thanks for the rest of the colleagues. Some questions to you, really. I noticed that the large increase in October of major incidents that we had. You've referenced some of them being related to some network issues. Outside of that, is there anything else we should be worried about?
So the major incident details are in the report. So the others are, we've had a succession of unconnected incidents. So if I just have a quick look at them. So we've had one relating to Microsoft 365, which was related to the data center change. There was a Welsh Reports Service incident, which was related to a service account. Then we've had a number of WPAS, WNCR incidents, which were service and system specific. So they were resolved by individual interventions on those systems. WRIS, I've mentioned, is hosted across, is distributed across the wider system. So yeah, there's no real pattern to the others, David, but we do review these regularly through our incident review and learning group, and then we take out any findings which we need to then extrapolate and undertake tactical or strategic activity on the back of. We do. So we're constantly looking for patterns in these, but I think the combination of a few coincidental issues plus these this tranche of network-related activity, I think, accounts for the spike that we've seen in October.
The other thing, when you look through the detail on them, Sam, is that I suppose you would regard this as encouraging. You wouldn't want an incident, but the resolution is of those that did breach is well within the SLA.
Yes. Yeah.
The SA allowance, you know, it's a matter of minutes rather than the hours, where which is the SLA, which is you don't want them, but they're getting resolved quickly.
Yeah, we've only had, I think, one SLA breach this year, so yeah.
Okay, Helen, and then Ridian.
Thank you, Chair. Yeah, just to pick up on the critical care programme, really, and just to emphasise what Evan has said there in terms of the delay now that programme is experiencing in terms of the go live, and to reassure the board, I guess, that we are working closely with colleagues in Iron Bevan and the supplier so that we can get to a revised implementation plan date for that ASAP, really. But lots and lots of work and discussions ongoing in terms of getting us to kind of the right place so that we can move that forward at pace.
And Ridian.
Thanks, Chair. This is a question for Sam. We have systems, of course, which are absolutely critical for the delivery of care, and we have some systems that, you know, if they go down during the middle of the night, it doesn't make an impact. Just for our education, the ability for us to transfer across our data centres from one to the other, that's in minutes, is it not? To keep things up and running?
It is, Ridian, yeah. So we have two tiers of criticality. So clinical critical are our most critical services, and those are generally we're able to instantaneously or certainly within a few seconds fail over between data centers, and we've actually demonstrated that as part of the preparation for the data center move. We're testing those failovers as part of that work.
Because the message is, as the service becomes more and more dependent on digital, we as an organisation have to invest in making sure that we can keep the light on. And really, I think, Chair, that's a sort of take-home message.
Yeah, absolutely. Thanks for that observation and the response, Sam. And there's just one I'd like to. It's an observation and a comment, really, but it's the slide deck you've got on people and OD, SJ, because, you know, in circumstances where money is very, very tight and resources are very difficult, and there's a huge focus on recruitment, then there's some key indicators in there that are really important, which I think you alluded to, the sickness absence and the turnover particularly. And it is encouraging to see that those that are not showing any at the moment any noticeable upward trend. So that is encouraging, and I think it's something we need to obviously keep a close eye on as we go through the rest of this year and into next year, which we know is going to be equally difficult. Any other comments or questions? No, we're asked to receive that report, which I'm sure we're happy to do, and move quickly on to the next item, 6.3. It's back to you again, Ivan, for the half-year performance against plan report.
It is, and I know we're over time, Simon, I believe, so I'm going to try and be quite brief on this one. You've got the cover paper, which is quite detailed, and you've also got the slides against each one of the delivery portfolios in the first four of our strategic missions. You remember that our first four strategic missions have got delivery portfolios, and then the last mission 5, which is the best one, according to Claire, has got enablers rather than delivery portfolios. So rather than go through each one, because we've covered quite a lot of them through the meeting, I just want to try and give you a kind of a flavour, I suppose, of where we are and my general reflection on performance and delivery through the first half of the year. Wherever I go across the NHS, within DHCW, in the organisation, everybody is reflecting on how incredibly busy they are. It is. They're busy, and lots being done. And I think the reflection of that is how long ago it feels that the app went into public beta, which was in April, in this half-year period. How long ago it feels that PAS moved to a single instance across the whole of Betsy Cadwallader. It feels as if it's in the dim and distant past. Even the NDR platform going live at the beginning of August feels a long time ago. And there's been, quite a significant amount of work since then. And today, as we are meeting, there's a big data event with more than 500 highly technical data people on it. And the chat, which I'm exposed to, is wonderful to listen to. But 500 people in a big data event, virtual, on the NDR. So it is really busy, and there's loads of delivery and achievement across various other things. And and I haven't even mentioned the turnaround in the LIMS and the risk programs, for example. Teams re-engineered, commercials re-engineered, timetables and timelines and delivery programs re-engineered, all of that negotiated with health boards. So I really want to pay credit to all the work that's being done across DHCW and with all of our partners across the health boards. It has been intense, and it continues to be really intense, and I think it's really impressive. We are facing challenges, as you know. Finance is a challenge. Recruitment, talent is a challenge. We have some programs that we are trying to turn around and to deal with and to receive, like the iCare program, which we discussed before. All of this is detailed in this report, which the board sees as a full board, and we cover a great deal of this activity, some of the fastest moving activity in the Programmes Delivery Committee, which is the new additional governance that we've set up to provide more scrutiny on that. So I think the most important thing, I wanted to just to convey that intensity, and I've got a really high level of pride in the organisation and what it is delivering in very difficult circumstances, but also to emphasise the transparency and the openness with which we're reporting on this, through this committee, but also through the Programmes Delivery Committee, to invite questions and comments on this. But the papers are all there for people to reflect on, and they're published, obviously. So if there are questions, then I or other directors will be very happy to try to answer those here in a public forum. But I didn't want to go through every single page and sort of read them out, given where we are on the agenda for today's meeting. I hope that was helpful. Simon.
No, that's fine. That's fine, Ivan. That makes all sorts of sense. If people want to, I'm going to make one observation, just in case people are thinking of what they might want to raise if they wish. And I was reflecting on this, I don't know, at some point this week, probably out with the dogs in the dark in the morning, is the level of growth and maturity of the organisation, which, as you pointed out, is, over very recent times, taken on some quite difficult, challenging programs that needed care and attention and tender loving care to bring them back to where they needed to be. But equally, and as again you've mentioned it, is that I think we've reached a point where we say no as well, and saying no is always far more difficult in a lot of circumstances than saying yes. So we know what can be achieved and what can be turned around, and we know those things where perhaps it's something more drastic than tender loving care is needed to get it into the position. And I think that's very much around the maturity of the organisation and the growth of the organisation as in its in the context of it being an independent statutory body. I just give that takeaway that I was reflecting on this week, and I suppose it was thinking about the iCare program. I suppose is what prompted it. Is we might, as an organisation, have taken a slightly different approach a year ago than we're currently taking, and I think that's a good place to be in, not a bad place to be in. So, anyone got any comments on the half-year performance? We've been asked to receive that. Thank you very much, Ivan. If I move then on to the highlight reports from the various committees of the board, and the first one, as I mentioned earlier, Marion is unable to give, though you've been an active member of the meeting already, Marion, and Alistair is going to give the anything that they want to raise from the last meeting of the Audit and Assurance Committee. Alistair.
Thanks, Simon. And just a few items I'd highlight, if I may. The first one being some concerns raised at the committee and raised a request for an additional internal audit review of the iCare digitisation programme. That was made by the committee chair. And I understand that's now work that is being led by Cardiff and Vale UHB in collaboration with DHCW. The board assurance framework deep dive discussion on sustainable funding highlighted the challenge of becoming a trusted strategic partner without a sustainable funding model and with the current financial restrictions. And that, I think, reflects some of the earlier discussion and some of the early items that we had in today's meeting. Very difficult situation. I'd highlight the 4 internal audit reviews were received for assurance, with 2 UK General Data Protection Regulation receiving a substantial assurance and stock management receiving a reasonable assurance, which were considered in the private session. 2 reviews were considered in the public session of hybrid working, which received a substantial assurance, and board assurance framework, which also received a substantial assurance. And just finally, the Welsh language report, the committee were assured to note the progress being made on Welsh language compliance within the organisation, and also noted the challenge in assessing job descriptions for Welsh language skills. The committee have requested a detailed update on this for the next committee meeting in February next year. Just a few items there, Chair.
Thank you, Alistair. I don't see any hands going up. So we'll receive that report from the Audit and Assurance Committee. We move then on to the Digital Governance and Safety Committee highlight report, and of course invite Rowan. Anything you'd want to particularly highlight?
So thank you, Chair. I'm not going to highlight anything particularly from the report. It was very straightforward and it speaks to the maturity and the functioning of the committee. Our assurance reports are very robust, and we've made the necessary changes to our standing orders to reflect the new Digital Portfolio Committee. And I just reflect that in a follow-up conversation that I always have with Chris Starling after a meeting, we were just really pleased to see the openness and the enthusiasm with which Rydian and Ivan and Sam's team come to the meeting and engage with the matters at hand. So thank you to them and their staff. Thank you.
Thank you, Rowan. And then again, we received that report for assurance, and then moving on to the Local Partnership Forum highlight report. And I think, Andrew, you were in the chair for the last meeting. You're on mute, Andrew.
There we go. You can hear me now. Yes, it was me in the chair. Yeah, so the report's been presented to the board on the papers. A lot of the things that we discussed were in today's board meeting. The usual sort of things like risks, workforce risks, sickness figures, PDRs, and ensuring people have completed statutory and mandatory training. I just wanted to praise the high level of quality discussions at the meeting. And just wanted to thank all those involved for their contributions. Nothing to be escalated to the board on this occasion, but I'm happy to take any questions that anybody has.
Thank you, Andrew. I don't see any hands up. We received that report. Thank you very much. And then myself, on behalf of the Programme Delivery Committee, as we've noted, this was the first meeting of this committee, and in some senses very much feeling our way through, and also a chunk of the meeting taken up with looking at terms of reference and similar. I think I give an overall impression, really, which I think the committee shared, is it was really useful to be able to see all of these programs on one page, if you like, and our ability to look at how they interact with each other and the impact they have as individual programs on the whole. I think that was a real benefit of this new program, this new governance arrangement. The three areas I'd raise, and two of them, and it's no coincidence that two of them have appeared throughout this meeting in the context of their level of risk or their importance. I mean, the first one is highlight the iCare programme and the attention we paid to that in the committee, and people will be well aware of where we are with that at the moment. The second one was, again, the committee very, very concerned, obviously, about the sustainable funding of programs, particularly as they move from in development into business as usual, and where that funding comes from. And there are some big, high-profile programs that are moving into that position in the not too distant future. And lastly, we've got a development session, I think on January the 18th next year, to look at so that the committee can look at how it agrees the scope of programs that will be considered by the committee, and in what circumstances specific reports for assurance and scrutiny are brought to the committee. So that I think I'm right, Chris, that's happening in the new year. There we go. I got no hands on questions. Okay, so moving on to the next page. Closing matters. I have had no urgent business brought to my attention. Does anyone have any? I hope not. No, thank you. And the date of the next meeting is Thursday, the 25th of July, and it goes against everything I believe in to say Happy Christmas in November. But please do have a very happy Christmas. But we will be seeing each other as a board. I know that before that. So I'll now bring the meeting to a close. Diolch yn fawr.